Good morning, everyone, and welcome to our opioid summit. Can you hear me? Yeah, all right. Maybe I can just work without it. I'd like to welcome everyone here today. I don't know if the mayor's arrived yet, but certainly welcome him. Dr. Burrell, our panelists, which is Dr. Monica Burrell, Cheryl Bartlett, Sarah Weiss, and Tina, make sure I'm pronouncing that right, Tina Lose. Is that right?
Yep.
Thank you. Great day today. We're going to have a great summit. Thank our organizer, Stephanie Harrington, the entire prevention subcommittee, which is kind of long for the work that you did. They get a great summit planned for you today. It's going to be action-packed. Of course, I already mentioned real quickly that we're going to have Donica Burrell, the Commissioner of the Mass Department from Public Health. Our panelist is going to include Cheryl Bartlett, the CEO of the Greater New Bedford Community Health Center, Sarah Weiss, Director of Planning and Development of the Department of Public Health, and Tina Lose from Regional Project Coordinator for Essex County Asset Builder Network. I think I get that right. And of course, we're going to be closing with our own representative, Christopher Hendricks. I'm not sure if he is here. Sorry, I didn't get a chance to say hello this morning. Good morning, Representative. Today we're going to be discussing, we're going to learn, we get to think about how we can continue to progress to overcome the opioid crisis. Our motto for our task force in our flyer says is Together Saving Lives. And Together Saving Lives, I can't think of a better description of what we do here with our task force, because truly it's our community coming together, and it takes a community, at least a team, to save one single life. And if you were to talk to our outreach team, who are amazing, and we had a meeting the other day at our office, and I think Connie was describing that they truly have become a family of a chaplain, a police officer, and a recovery coach. And it takes that kind of team and a bigger team, as we have on our task force, to start to turn this around and truly save lives. So together as a community, to develop a capacity, the ingenuity, the passion, the empathy, understanding, resourcefulness, and transition that into a community of action. And that's what we hope you get today in your discussions and your deliberating and your thought process and your imagination on how we're going to start to push this thing forward. We can no longer wait for just funding or someone else to come and save us, and that's what our task force has done. We haven't just stood idly and said, well, someone's going to come up with a solution. And we've come together and we started to use what we have at our fingertips to start to make the difference. Ladies and gentlemen, I'm proud to tell you that is exactly what our Greater New Bedford Multidisciplinary Task Force has been doing. When I was newly appointed as Chief of Police, Mayor Mitchell allowed me to chair this task force, and Dr. Michael Rocha joined me as the co-chair. And I want to take a moment to thank him immensely for his collaboration and his friendship. He recently had to step down, an amazing man and completely committed to this community. So I don't think he's here, but thank you, Dr. Rocha. Before I discuss briefly some of our initiatives, I want to express my sincere gratitude to every member of the task force. You see, this is a group of amazing, passionate, and dedicated people, and our true insight to the New Bedford and our community and who we represent, our culture and our historical resolve, not only in this issue, but in the past for other issues. This is an amazing community of beautiful people. If you had the opportunity, and I invite you to come to any one of our meetings every third Thursday at 1 o'clock, and what you're going to see is a group of robust people. There is no room, and we're literally busting at the seams, and this is every month. Committed people. They're just amazing. I can't say enough about them and how proud I am to be engaged with such amazing people. My voice is going, I'm sorry. One of our earlier meetings, I recall someone suggesting that we should begin to develop frameworks so that we could start pursuing funding and things of that nature. At the time, this was in 2016, my response was, we don't have the luxury to sit idle and develop frameworks and seek funding resources. People were and are literally dying We need to act and utilize whatever resources we have available and then work on our frameworks. And that's exactly what's happened with this amazing group of people. We started in 2016, and we started just throwing everything that we had at this problem, and we'll talk about it a little bit. And now you'll see that we are developing frameworks and strategic plans, but we just didn't have the time. This crisis was hitting us like everybody else, and we just literally had to put our foot on the pedal and hit the gas and hit a few trees along the way, but in the meantime, plucking as many people as we could into a road of success and rehabilitation. The task force was it was able to secure early on in, I believe it was 2017, with the good Dr. Caldis's assistance. He was able to give us some small money to put together a training for recovery coaches, which was a big deal for us. It was a big step. From there, we also developed a recovery coach outreach subcommittee. Currently in New Bedford, we have a 24-hour overdose outreach team that responds to every single overdose with an amazing team of a plainclothes police officer, a chaplain, and a recovery coach. 6 days a week. I like to go to 7, but chaplains work on Sundays, so it makes it a little bit difficult. That's their big day. But I always tell Reverend Lima we're doing 6.5 days. We're going to go without the chaplain. So we do about approximately 30 attempts a week with about a 30% contact success rate. And if you talk to these folks that do this work, Connie, Reverend Lima have been doing it for a while, they'll tell you how amazing it is when you get it right. When you have that moment, when someone, that window of opportunity, and that person's all in, and you can get them on the right track, or just affording services to the family. They do amazing work. In early 2017, we were lucky to have Fairhaven and Dartmouth join our task force, both police chiefs and the health department, which is a big deal for this region. Why? Because we know that these folks are transient. They bounce around from community to community. And we also know there's strength in numbers. So we have Chief Myers here today. We're grateful for him and his team and the health department and Dartmouth as well for joining us. And it is making a difference. Our motto is together saving lives. And when you bring these other communities together and we expand our multiplier, a factor multiplier, that's how we expand the opportunity to save more and more lives. So we're very grateful for them. Our prevention subcommittee is, we have also a prevention subcommittee who is currently working on one of our biggest challenges. And the biggest challenges facing us today with this crisis is preventing or diverting the next generation from the pool of addiction. I can tell you they're working on some really cool stuff. They're working with mindfulness in the schools, trying to develop that. We also got a small grant from South Coast. Again, thank you, last year to start a pilot program. But our prevention team is working closely with the school department to get that up and running. They're also working with the community that cares, putting a survey to 6th graders. They can talk more about that, but imagine is we're trying to identify the trauma levels in those individuals and get them into the resources that they need. I've been a big advocate for the ACEs survey for the 3rd grade. I believe that is a big deal if we can get that into play, because if we can identify these kids that have reached that level of trauma and then wrap around those services, not only can we start to divert the social ill behaviors, but the health issues as well down the road. But they're doing amazing work, the prevention subcommittee, so we're very grateful to them. We also have a drop-in center subcommittee. We had our first drop-in center in 2017 with resource providers for both the victim and their families. We provide a drop-in center throughout the year at various locations. We started at a fixed post, but we found that didn't work as well, so we're adapting and changing. We're grateful for that committee, for the work they're doing. This year, we just started another subcommittee. Waterfront Outreach Subcommittee was added to focus on the fishing industry. Deb does a whole lot of work there. Thank you, Deb. Appreciate for everything that you do. She truly, you can tell she wears her heart on her sleeve and she cares. Very passionate. In 2018, I'm proud to tell you the New Bedford Police Department added a LEAD program, a law enforcement assisted diversion program, which is with the collaboration of our wonderful district attorney, Tom Quinn, and our mayor and the Bedford Police Department, we now have an opportunity to take individuals and divert them from the criminal justice system and burden them with a charge on their record. They commit a small crime that is driven by addiction. We have an opportunity of diversion into our program with Seven Hills is one of our big collaborators. And if they fall off the wagon, we don't throw them off the program. We keep them in there. We keep working them. I can tell you we are up to, I believe, 24 candidates in there. We received a beautiful letter. I wish I could share it with you, from a lovely young lady who was working in the cities, the streets in North End, has turned their life around to that program and a group of people coming together to save lives. Just a wonderful program. We're really excited about that. This year, we adopted the case management model for our recovery coaches, which I also think is a big deal. In 2018, we began to formalize our organization, creating an executive committee led by our wonderful public health director, commissioner would be probably better, Damone Chaplin. We are now working on a strategic plan. We've hired an outside consultant, so we're well on our way to formalizing our organization and looking to the future. Big step for us. The police department and health department, we are going to be very shortly sharing data. Another big deal, because as we know, data tells a story. And when we have a story, then we can start applying our resources. So looking forward to that as well. Earlier this year, the Bedford Police Department hired a crime analyst who gives us real-time analysis so that we can deploy resources. We've seen the effects of that in January. We had a big uptick in overdoses and fatalities, particularly in the segment in the South End. Because of that analysis, we're able to take out our outreach team and saturate that area with our enforcement team. And shortly thereafter, we had some raids, and we've seen it start to drop down. So we're excited about that as well. Bioanalytics will be providing valuable information. That's going to be really amazing, and that is cutting edge. So, and I think Damone is very responsible bringing that here, so thank you for that. Nasal Narcan training and distribution is not new to New Bedford. I believe we were one of the first few to implement that in the state. Again, I go back to Connie and her team. She's training not only police officers, but civilians as well, and deploying that out every day. So that's a big deal when we talk about saving lives. It remains our goal to eliminate the stigma that is attached to this addiction. And that is a big goal for us, and we're working towards that every day. So to wrap up really quickly, because I see my boss just walked in through the door and he's going to be coming up. There is so much synergy here, and lives have been saved. Sadly, not as many as we all would like. And more concerning to me is the next generation that we must divert from this disease. If the synergy and the momentum on our task force is to be our barometer, then I am confident and optimistic that we will have the impact that we sorely seek. I cannot express my sincerity and my gratitude to each member of our task force. Truly, truly amazing and beautiful people. Come to one of our meetings and you'll see that in action. Our task force truly supports the words, and this is my one quote for today. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. That's by Margaret Mead, and I think that our team represents that. So, with that said, I would like to introduce to you my boss, and I'm grateful to his support. He's been very supportive of this task force and everything that I'm able to do with the police department, our Honorable Mayor of the City of New Bedford. Please welcome the Honorable Mayor, John Mitchell. Thank you.
All right, good morning, everybody. I walked in and had a great first impression. I thought, wow, this is quite a turnout. And I guess I shouldn't be too surprised after all, because, you know, here in Greater New Bedford, there are a lot of folks at work on these issues, and many of whom, but not all of whom, are in this room. And then, of course, we have great partnerships with the state that we rely on as well. And in that way, I want to thank my good friend Chris Hendricks, our new state rep, who's made opioid addiction in particular, one of his prime priorities, and is already looking for ways, even as a freshman representative, to find money to support the efforts of the task force. I wanted to thank just a couple of other partners, Monica Burrell, the State Commissioner of Public Health, for being here today, and for the partnership that we have with you. We really appreciate that. And then Cheryl Bartlett, of course, from the Great New Bedford Health Center downtown, someone who's been in the midst of all of this. And then, of course, the leadership of the task force, Damone Chaplin, our Director of Health, and of course, Chief Cadero. Thank you to all of you for being here today and for all that you do. And I suppose I could go right around the room and just sort of point at people like Dave Lima and so forth, and just thank a lot of folks because, you know, at bottom, the work of the task force is a granular one. We have a daunting challenge nationally in curbing opioid abuse use, and that work has to happen not only at every level of government, but it also has to happen right at the street level. That is to say, it has to happen in close coordination between the public sector and the private sector, and it has to be granular. It has to be almost like a political campaign, trying to prevail upon people, whether they are experienced substance abuse or are family members or friends or otherwise connected, one person at a time. And you know, we've been gaining traction since we formed the task force in 2016. We've worked and got up and running. We've seen some significant results. From 2016 to 2018, we saw a 35% drop in overdose deaths in the city, which is significant, really significant, and it should be not so much a source of pride, but a source of confidence for the work that we've been doing. I say a source of confidence and not pride, in the sense that we know what we're doing is making a difference, but at the same time, we can hardly say we're done. I mean, we've, you know, as soon as the 2018 closed, we saw, you know, almost immediately a spike in January. In fact, we had, I think, Chief, correct me if I'm wrong, I think it was 10 or 11 overdose deaths just in the month of January, and we think that was attributable to one or two fentanyl dealers that the police promptly took off the streets. Were able to, you know, through good detective work, figure out the source of what had killed those individuals, and then were able to deal with it. But it's those kinds of things. I mean, for every 2 steps forward, there is a step backward sometimes, and I'm just here to say, keep going, because it is making a difference. Every single person that you touch in some small way, and it may not be immediately evident, is put on at least a step in the right direction. The work of the task force includes it's a multifaceted effort. Of course, it includes law enforcement interdiction, which is an indispensable element, but it also includes, of course, the clergy ride-alongs, the drop-in centers, the LEAD program, which we've been pardon the pun, we've been a leader in over the last few years, or last couple of years since we started it up, and are keeping it going now. So, and it's making a difference as far as the ride-alongs go. We've had, and the outreach teams, we've been able to contact. We've made 1,000 visits and have been able to successfully contact in the last couple of years about 350 individuals, which is quite significant. And you know, you will never know precisely the effect that those efforts had, but we can rest assured that they are making a difference. So I'm here to say, you know, thanks for the hard work. We've got much to do in the weeks and months, and frankly, years ahead. We know that this is not an overnight exercise, but if we continue to work as we're doing, Greater New Bedford will continue to be a national model for what can be done at the local level. So, thank you for all of your help and support, and let's keep it going. Thanks, everybody.
thank the mayor again for that welcome. Thank you, Mayor.
Jamal, I want to check the microphone to make sure it's on.
Okay, great. There's a few here. How about now? Can you hear that? Okay.
Can we start over now?
Good morning to everyone, and thank you for joining us today. I no longer can use the title of a newbie anymore. I've been here now for a little over a year, so I have to shed that title now. I would first like to thank the mayor for his support and leadership in this truly trying time. It takes courage and conviction to principles and goals to manifest change in the face of despair, and he has done that. I would also like to thank our federal and state representatives. Should there be any in the audience, please rise and just be recognized. Do we have any? Chief Jackman. I would also like to recognize, and I cannot say thanks enough to our team of change agents and task force members, those who came before me, Chief Cordero and Dr. Rocha, and all the members who have supported this task force and efforts going forward. I'd like to say thank you, because without them, I couldn't be here today. They worked so hard and diligently to make changes within this region and make the community a stronger and more prosperous community. And I'd like to thank them. I'd like to thank my staff and partners in change. Are the staff here, New Bedford Health Department staff, please stand, be recognized. Stephanie. And the others are probably in the back. They've been working with me over the past few months to organize this event, and even today and last night, getting here early and leaving late. Again, I thank you for helping me through my transition to this work and to this wonderful community. I'm new to the area, but not new to this experience and not new to some of the struggles that we're facing here in New Bedford. And so this is a beautiful city, and I'm so happy we were able to get this particular space, because I think it really highlights what I call the hidden gems of New Bedford. This is one of them. And so I'm so happy we're able to experience that with you. And last but not least, I would like to thank the Carney Family Foundation and the Massachusetts Department of Public Health, the Bureau of Substance Addiction Services, for their generosity and continued support. Without them, we would not have been able to put this program on. So, Tanya, thank you very much. And is Glenn here? Glenn, thank you very much. Katie, Cardi, Jen Atkins, Glenn Oliveira, and Tana Fernandez. And to all of you who are joining us in the fight against this disease of addiction, despair, destruction, I thank you. We have a packed agenda today. My role here is to set the table for you. So I ask that all presenters and meeting organizers to be mindful of our presentation guidelines and time restrictions. This is intended to be a working breakfast, so if you haven't had a chance to get your food, please, in an orderly way, get your food and come on back. Please be mindful of your unintended distractions, which may be associated with your meal consumption or your supportive comments among friends and colleagues. So today's program will be broken up into 4 sessions. We have the beginning section, which is going to be we'll be talking about our new technologies and our planning. The second section will be our keynote speaker, our panelists and questions and answers. Our third section will be the actual breakout section. So if you look throughout the room, you'll see the room separated into 4 sections. A section here, a section in the corner, a section in the back, and a section behind you. And so during the breakout section, we'll be broken up into 4 sections talking about prevention, intervention, treatment, and recovery. And then our last section, which I think is the closeout for the day, will be the call to action from our representative, Chris Hendricks. And so that, in the short realm of things, will be the layout for the day. There will be some intermittent breaks in between there, between transitioning between presenters, where you'll have a chance to answer a phone call, return an email, or maybe take a bathroom break. If you were able to navigate yourself to this room in this building today, you should have no problem to find the bathrooms. They are down the hallway and to the left if you haven't already seen them. There will be a 5-minute break at the end of the question and answer period and before the breakout session. So that will be an actual scheduled break within the day. So you'll have a chance to regroup and get yourself together at that point. And maybe even go out into the side here and enjoy the incredible scenery that we've provided today. So without further ado, I would like to introduce our first two presenters. I'll do the introductions for both of them so that you can just come up simultaneously after one another. Our first presentation will be from Nusha Gailey and Dylan Enright from BioBot Analytics, and Shay Fuxman and Jessica Goldberg from the Prevention Solutions at the Education Development Center. The EDC and BioBot. BioBot will be providing us with some technologies for our task force going forward. This is some very new technology, and I'm excited about having it available to us and using it going forward. And Prevention Solutions at Education Development Center, they will be doing the strategic planning for the task force going forward. BioBot's Ms. Gailey was a fellow at the, oops, take this off here. Ms. Gailey was on fellowship at the MIT Sensible Cities lab investigating the future of cities through new technologies. An architect by training, Ms. Gailey has led teams at MIT and the World Economic Forum implementing innovative city solutions. Ms. Gailey holds an undergraduate degree from the University of Waterloo and a Master's of Architecture from McGill University. Dr. Shay Fuxman, Senior Research Scientist at Prevention Solutions and Education Development Center, is an experienced education and public health researcher with expertise in opioid and other substance misuse prevention. As a training and technical assistance specialist for Prevention Solutions at EDC, Dr. Fuxman provides consultation to community and state agencies. He also leads EDC's Opioid Working Group, which develops and promotes strategies for supporting communities affected by the opioid crisis. In both these roles, Dr. Fuxman conducts research, develops tools, and presents on substance misuse prevention topics, including but not limited to strategic planning, program evaluation, effective strategies for preventing opioid misuse and overdose and substance use preventions among youth. Jessica Goldberg, training and technical assistance specialist with Prevention Solutions at Education Development Center, is an accomplished designer and the deliverer of in-person and virtual trainings that address topics ranging from collaboration across health sectors to identifying and addressing health disparities. For the past several years, she worked closely with states and communities, coalitions to adopt and apply SAMHSA's strategic prevention framework to develop and implement evidence-based strategies to prevent substance use. So without further ado, please welcome Ms. Nusha Gailey and Dylan Enright.
Well, thank you so much for coming this morning. Chief Damone, thank you so much for having me. It's really a wonderful, it's so wonderful to see so many people coming out to an event like this. I meet with quite a few cities now and then, and definitely what the New Bedford Opioid Task Force has done, bringing people in this community together, is really remarkable and not something that you see every day. So I'm going to talk to you a little bit about BioBot Analytics. I'm one of the co-founders of BioBot. I am an architect, but I'm a co-founder together with my partner, who is a computational biologist, and it might make sense a little bit further on why a biologist and an architect are working together. And what we're doing is developing a new way or a novel way to assess the opioid epidemic across America. So really developing a new metric to understand how things are going. And we're doing this by using wastewater epidemiology, which I'll explain in just a second. So why are we generating more data around this? This was in part spurred by us realizing that the best data that we have today to understand the opioid epidemic is counting overdoses. And while this is very important information, this is an extremely reactive metric. By the time somebody has overdosed, we're really in damage control. And also a very small number of people who suffer from substance use disorder are overdosing. Moreover, the data is very reactive and stale. So this plot, for example, was published by the New York Times in November of 2018, and it shows overdose deaths to 2017 only. So this data keeps us looking backwards rather than giving us a real-time understanding of how things are going in our community. And so what we're doing is measuring the concentration of opioid metabolites in sewage in order to map consumption in cities. And it's actually a pretty simple concept. So everybody pees every day. And we all know that there's a rich source of information that's contained in our urine. Our doctors look at it all the time. And all this information is collected and aggregated in public sewers, an infrastructure that's owned and managed and maintained by cities, but it's not being tapped into, or the data is not being uncovered or looked at. And that's because it's actually not that simple. It requires a lot of different disciplines and a lot of different departments coming together in order to actually extract and analyze this information. And so at BioBot Analytics, we actually are doing the entire technology pipeline, from the mapping of the wastewater network all the way through the actual mapping of the concentrations of the opioids in the city. So we're leveraging IP that my co-founder and I developed while at MIT. We were there for about 3 years doing research on this before starting the company last year. And very quickly, how it works is we start by mapping a city's wastewater network. So this is Cambridge, Massachusetts. And we overlay the wastewater network in a city with census data and demographics, as well as population size, so that we know that if we're collecting a sample from a given manhole, exactly what the upstream catchment area is that's flowing through that manhole. And then we can look at the census data related to that community in order to inform public health interventions, programming, and response. So we end up with a map that looks something like this, dividing up a city into smaller areas. And we mandate that each of these catchment areas represents no fewer than 4,000 people. They tend to be more in the tens of thousands of range. And that's really because this data is used to inform public health, which operates at that community level scale. So we're creating these community level catchment areas. We then have a hardware unit that we've designed and that we manufacture that gets deployed in the manhole and sits just above water level, taking a continuous subsample so that every single person who lives in that area would contribute to that sewage. At least at some point in 24 hours, we assume that everybody uses their toilet at home. And then the concentrated sewage in these cartridges comes back to our labs. We're headquartered in Somerville, where we're measuring these 30 drug metabolites. Now again, we're measuring the metabolized version of these drugs, so what is excreted in urine as opposed to the parent drug. So our data is not confounded with what people may be flushing down the toilet. We're measuring illicit opioids like fentanyl, heroin, fentanyl analogs, over half a dozen prescription opioids. We can distinguish between the types of prescription opioids, treatment therapies like Suboxone and methadone. We're also measuring Narcan, the overdose reversal drug. And we've also recently included some emerging drugs of interest, including methamphetamines, cocaine, MDMA, and cannabis. Now, once we get all of this data, we visualize it and map it into monthly reports that we give back to the city. But what's more important is the actual insights and the action items that these reports give to the city stakeholders. And instead of showing you a report, I'll walk you very briefly through a case study. Our first pilot project that we did in the town of Cary in North Carolina. We worked with Cary for 6 months last year. We finished the pilot in December of 2018. And last year, for the first time, Cary saw a 40% decrease in overdoses, which they attribute to really the conversation that was started because they introduced this. Cary had no opioid response programming prior to this. And so they're now going to be moving forward with more sampling from us restarting in the summer. So we start by mapping Cary. And for those of you that are familiar with the town of Cary, the map has been anonymized, so you might not recognize the footprint, but all the spatial relationships of the catchments are maintained here. So we map the catchments in Cary. And then once we actually get the data, what we're doing with those concentrations is converting them to collective consumption rates. So what you see on the right is reported overdoses as given to us by the town. So that's data in 2018 that the town collected. On the left, you can see the collective consumption rate of all opioids per capita across all the catchments that we measured. Now, overdoses in Cary have always clustered around one particular area, that's the downtown core. However, our data on the left showed that we actually saw quite consistent consumption everywhere in the city. There were some communities, a couple of the catchments, that had seen 0 overdoses in 2017 and 18. However, we measured almost as much opioids in wastewater as some of the catchments where they had the highest rates of overdose. So really revealing to the city these hidden areas and these hidden communities where they were not providing any sort of public health programming or response or outreach. Here, we're looking at that same overdose map on the right, but on the left, we're plotting Narcan as measured in sewage by our technology. Now, Narcan was the one chemical that correlated the most with the overdoses that we saw. However, we measured almost 30 times more Narcan in the sewage than those number of overdoses would have required. So what that's telling us is, great, Narcan's getting into the right hands. So their Narcan distribution avenues are working really well. But there's a lot of bystander and private use Narcan rescues that are happening that are not being reported to emergency services. Why? What are the barriers that are in place in these communities that they're not reaching out for help? And so that's another thing that the city's now taken on to try and understand and address in their upcoming programming. So in those 6 months, what happened during our pilot in Cary was really a robust public education piece component, something that they didn't have prior to this. So they really started with community engagement. What used to be a not my problem really turned into, this is something that's happening in our community and that we all need to participate in. So the mayor and the city manager and their health team held about 50 town halls centered around, this is what the sewage is telling us, and so we can't, ignore this problem because it's coming from our homes and not people from the neighboring towns coming in. Cary found that prescription opioids were driving most of their consumption, and so they really targeted and tailored their messaging around that. And in the time of the pilot, had a 3-fold increase in prescription medication drop-offs in the units that they had set up. And now they're using this data to design their first set of interventions and ongoing strategies, like I mentioned. Now, while those may be the applications or the takeaways for Cary, there's so many other things that some of the other cities that we're talking to will be using this information for. Again, really reducing stigma. That's something that happened in Cary. Helping inform these educational and prevention campaigns in schools around language, with communities, optimizing Narcan distribution, equipping EMS with real-time knowledge on emerging trends, so the fentanyl analogs, meth, cocaine, tracking the impact of policy and programming, for example, around cannabis. How is that legalization going to be impacting the communities in terms of cannabis consumption or opioid consumption? And then finally, a tool to showcase wins and really enable the city to talk about consumption going down. And so in Cary, we did this 6-month pilot. It was sponsored by Bloomberg Philanthropies. They were lucky to get a grant from Bloomberg, and now the town is building this into their budget in order to get ongoing data on a month-to-month basis to really track the evolution of the programs that they've launched. And one thing that I want to talk about is really privacy and transparency. This is something that's core to us as a company, and given the fact that we're the first company that is doing this type of work, it's an issue that we want to talk about and sort of lead the conversation on. Nobody has looked at wastewater before for information like this. And so we mandate privacy by having this population limit when we sample, so no fewer than 4,000 people in a catchment area. The same legislators that we're working with in order to get this introduced into communities, we also are working with to set up the first sort of ethical guidelines around how we use this technology and how this data is protected and communicated with different stakeholders. And finally, every single person has a voice when it comes to our city's sewer system. So we're counting everyone. No one's being left out of the data with a technology like this. We're also talking to legislators and folks at the federal level. The president had a commission on his opioid task force, the Opioid Commission, which Governor Baker was actually a member on. And one of the 50 recommendations that were made to the president, to the White House, included filling in data gaps using technologies like wastewater epidemiology. So we're working both at the state level and the federal level to really implement these ethical use practices around this. Because again, we're the first spin-off and the first company that's doing this work, and we're starting here in Massachusetts. We're excited to be starting with the city of Boston. We're excited to be starting here in New Bedford soon. We're really looking forward to growing to more cities in the area. But this technology isn't entirely new. We've just sort of improved it during our work at MIT in order to be able to implement in cities and work very directly with public works departments and health departments. And I want to end by saying that this work that we're starting here in Massachusetts, while we are focusing on opioids and drug consumption, we're really paving the way to build out a brand new public health infrastructure, because the applications of this extend far beyond just opioids and drug use. We're developing a new type of public health observatory to look at infectious disease outbreaks, building out an early warning system for infectious diseases, viruses as pervasive as influenza or as one-off as Zika. Also an early warning system for antibiotic resistance genes, understanding the emergence of antibiotic resistance genes in our communities, looking at nutrition disparities, contaminant exposures, and then finally, that evaluation piece, that rapid evaluation of public health policy. So I'd like to thank, again, the New Bedford Opioid Task Force in joining us on this mission, and I look forward to the rest of the day. Thank you so much.
Good morning, everyone. I will tell you what I whispered to my colleague Shai as Nusha was speaking. That is one tough act to follow. It's such interesting and impressive work. So thanks for that. So my name is Jess Goldberg again, and I'm a training and technical assistance specialist with the Education Development Center. And we're so happy to be here. We want to thank Damone and Stephanie and the folks at the Health Department, the Executive Committee for the task force, and all the task force members for all the work that you're doing, the tremendous work. It's a pleasure and an honor to play a small role in it, and helping with the strategic planning process, as Damone's mentioned. So I'm going to talk a little bit about our approach overall, and then I'm going to hand it off to my colleague Shai to tell you a little bit more about the specifics of what will be happening and what is already underway in New Bedford. And so we've already gotten to meet quite a few folks across the community, speaking with them and getting their perspective on the work that's going on in the community. But for those that we haven't met yet, we just want to take a minute to introduce ourselves. So we work for the Educational Development Center, which is a global nonprofit that looks to find solutions to education and public health problems and also expand economic opportunity both at home and abroad. And so our specific initiative, we know that EDC, there's many projects at EDC. Some of you may know our colleagues from the MassTap project, who I know have done work in this area as well, and lots of other projects here. But our particular initiative is called Prevention Solutions, which is a new initiative that's building on EDC's experience in providing workforce development, training, consultation to states. Honestly, we worked mostly at the state level for many years in preventing substance misuse and related problems. And now what EDC has done is expand this work out. So we are continuing to work at the state level, supporting grantees and doing that work, but also are able to partner with communities and local organizations. And that's how we got connected to the task force here and became part of the strategic planning process. And so, again, we're looking to help, through this process and partnering with different organizations in the task force here to create a comprehensive strategic plan around preventing opioid overdose in this area. So I'll talk a little bit about our approach and the lens that we bring to strategic planning. Can I just get a quick show of hands if anyone has seen this graphic or is familiar with this model? Great. So some folks in the room have encountered this, but this is just one example of a model to guide a strategic planning process. It's called the Strategic Prevention Framework. And you can see there's several steps in the process. And it starts at the top in assessment and sort of works its way clockwise around. And so there are lots of other models to guide strategic plan, but this is the outline that we sort of use in our thinking about it. And you'll see it really starts with assessment. And so a lot of what is underway currently, and Shai will talk about a bit more for this strategic plan, is looking at the data that exists already within Greater New Bedford, collecting additional data to figure out sort of what's going well in addressing the opioid crisis. Where are the areas or gaps, areas of improvement or gaps that could be filled, and how can we be very stepwise, logical, and strategic in moving forward in prioritizing the strategies that are going to be most effective in addressing the crisis. The model continues with assessing and building capacity to do this work, and then really creating sort of a stepwise plan for implementing strategies and evaluating their effectiveness. And then you can see in the center of the model, the focus on making sure that both the process and the positive outcomes are sustainable is a really key interwoven theme here with the strategic prevention framework, as is making sure that our work is really culturally responsive to the different groups within a community and that everyone is included and has a voice in the process moving forward. So that's the lens that we bring sort of globally to strategic planning. And then thinking a little bit about our scope, this is the behavioral health continuum of care and to our mind. And so some of you may have seen this image or something like it before. But when we're thinking about the work of the task force and also the specific work of this strategic plan, we like to think about it, and I think need to think about it in terms of covering this entire expanse of this continuum of care. So thinking about, walking through from health promotion and prevention, really focusing efforts on preventing, use generally, use among populations that are at greater risk for overdose, or who maybe are already using to try to make sure that, harm and overdose are reduced. And then thinking about, in terms of treatment, making sure that those that are interested in if and when would like to use treatment supports have access to them. So we think about who those people are, whether or not they do have access to use that treatment and are receiving the high quality treatment that they need. And then also thinking about how to support folks in recovery for the long term and making sure that those resources are really readily available within a community. And so this is sort of the universe of what we are looking to do. And so, like I said, for the strategic planning process, part of the focus is on what's working well, but again, part of it is also on sort of what's needed and what's missing. And so to that end, we begin to have some conversations with folks in this room and beyond. And we're going to be continuing to solicit input. Actually, as part of today's breakouts, everyone in the room will have an opportunity to weigh in on the process and share their perspective about the work in this community and surrounding communities, what's working well and what else needs to be done. But some of what we've started hearing is sort of an emerging vision for the plan and for the work moving forward. And so we're hearing that in terms of prevention, folks are really interested in preventing a next generation of opioid users and also supporting those that are impacted by opioid addiction, particularly youth or children in the communities. And we've definitely also heard that we want to be in a supportive role of those that are currently using and making sure to be actively preventing overdoses and encouraging access to treatment and recovery services. So again, we'll have a little more time for input today, but I think now I'll turn it over to you, Shai, to talk a little bit more about the specific process we're using here in New Bedford.
Thanks, Jess. And thank you all for having us and for inviting us to be part of this process. As Jess said, we've been doing this work for a couple of months now with Damone, with the chief, and with the executive committee of this task force. I want to tell you a little bit about what exactly we're doing here in New Bedford. We're not here to tell you what to do. You already are doing a lot, and we are here to facilitate a process to figure out where are you at now and what are the next set of strategies, or what are the ways to build and improve to get you to where you want to be in the next several years when it comes to helping those struggling with opioids, as well as to prevent more people from struggling with this disease. We're here to facilitate a process, and we're here to document what you're already doing. We're here to tell your story. And that's what we're going to be doing throughout this process, beginning today with these conversations, as well as through a survey that we'll be sending out to all of you to hear what is it that you already are doing. And then second, once we figure out what is already happening, and once we get a sense of what is your vision and your mission, it's to help to capture your ideas, your energy, and your passion to figure out how to take things up to the next level, and ultimately to meet your vision of working together to save lives. As the chief said, although I would argue, based on what I know already, you're doing more than just saving lives. You're also working to protect lives and to support lives for people struggling with opioids as well. So the first step is to engage with all of you. So we have the Greater New Bedford Opioid Task Force. We've also been talking to some of the colleagues in the Department of Health about how to bring even more people, how to get more voices heard, more diverse perspectives, diversity in terms of cultural, linguistic, but also people who just might be thinking differently about it, to really get a sense of what is it that people are talking about. Obviously, we're going to be working with the executive committee in particular, just to lead to help facilitate them in their leadership of this process. We're putting ourselves there as a partner. We're going to be working with you. We're also going to be working with a couple of other partners that the Department of Health has brought in to help the city of New Bedford and the surrounding communities, including UMass Dartmouth, that is doing their own strategic planning with the Department of Health that is broader than just the opioid crisis. They're going to be conducting key informant interviews. They're going to be doing focus groups. So we're not going to replicate the process. We're going to work with them. We're going to share information. We're going to share our survey data with them. They're going to share their focus group and interviews with us so we can get a better picture. Also, the National League of Cities is also working with the Department of Health. They're going to be evaluating some of the programs that you're already doing. So again, that will go into our process as well. So the idea is really to work together with all of you and with all the partners that you've brought in. Missing here is BioBot, but it's fascinating the kind of data that they would be bringing. And of course, we're going to be thinking about that in terms of how does that data feed into your planning. So I'm going to talk specifically about some of the steps that we're taking in the context that Jess talked about, the strategic prevention framework. So first is setting a vision and mission. We've already began that with the executive committee. We're going to be hearing more from all of you about what is it that where do you want to be? What is it that you're trying to focus on? As Jess said, we've been hearing things about preventing the next generation of users, so focusing on prevention. We've also heard about supporting those who already are using and who are already struggling with addiction, but also not only them, but also their family members, and particularly children who might be impacted by opioid addiction in the home. So that's the kind of things that we've been hearing, and we're looking forward to hearing more of those conversations and ultimately help you to develop a very clear, ambitious, and achievable mission and vision. Then there's assessment. Assessment begins not only with understanding what are the issues, what are the challenges, what are the problems around opioid use and overdose. That's obviously a part of it. We need to get a picture of the problem. But it's also about documenting, like I said before, what is it that you guys are already doing? So we're not starting from scratch. We're not telling you how to start this whole process all over again when in fact you are already doing so many amazing things. And what is the current capacity? How not only is the current capacity of individuals and organizations, but what is your capacity as a community and as a task force to work together? Is there strong coordination? Is there strong communication? Is there good data sharing? Those are the kind of things that we're going to be looking for and documenting so that we can help you figure out how to, again, strengthen your efforts. And what is working and what is not working as well. What is not working is important too, because that will help us to, again, build your capacity. The next steps is the planning. So, once we figure out here's where you are, we're going to be talking to you, and again, this will begin today. So this is not step by step, but it's kind of parallel processes. We're going to be talking to you already about what is it that you're thinking about doing next. What is it that you need to do more of? What is it that you want to put together into this big master plan for the task force? And then, this is the most important thing. The worst kind of strategic plan is the one that is very strong, very well written, a lot of thought goes into, and then it gets documented, put into a shelf, and nothing ever happens to it, because that's time and resource that was spent that goes nowhere. So the implementation and evaluation are going to be very important pieces for what we hope to do, to the conversation which we're hoping to facilitate. Not only what is it that we're planning to do, but how is it going to get done? How do we make sure that we have timelines, that we have milestones, that we have that we can document process, and that everyone knows what their role is in this process, and how to hold how you hold each other and yourself accountable for the implementation and evaluation. Evaluation is one of my areas of strength in particular. People are always scared of the word evaluation. No one likes to be evaluated. You always feel like, going back to school, having your teacher tell you how bad you did on the test. That's not what evaluation is about. That's not our approach to evaluation. Evaluation is part of the process of building your capacity and continuing to both document the impact that you're trying to make, as well as to make continuous refinements and quality assurance to make sure that you're doing what it is that you're hoping to do, and if not, how to improve it. So I want to just leave with the questions that we're going to be talking about today when we break out, just so you can start thinking about it. So we're going to be asking each one of you in the groups, prevention, treatment, intervention, and recovery. What are the efforts that are currently going on? What is it that you know? What is it that you're doing? And what is it that you know that other people are doing? And again, this is part of being able to capture your story. What is it that is already happening? And what's working from your perspective, and what's not working well? What do we need to do more of? And what role do you see yourself as an individual and the organization or agency that you're presenting to make that happen? And again, this is all the information that we'll begin with capturing today, but we'll continue to gather in the weeks and months to come. I also wanted to mention the survey once more. We're gonna develop with Executive Committee an online survey, which every single one of you is gonna get. We're also hoping to expand it to not only the people in the room today, but those who are not in the room. And I don't just mean physically those who are not in the room, but those who tend to not be in the conversation. We really want to figure out, how do we get the voices that are usually not heard? How do we make sure that everyone's perspective is brought in? So what I want to do today, right now, is ask you, not only please fill out the survey when you get it, and we'll talk about timeline, we'll figure out the timeline, but also help us identify who's not in the room, who needs to be reached, and how can we reach them. The more people we can reach, the fuller picture we'll have, and the better the plan will be. The more buy-in you'll get, and that's another key element for successful implementation. With that, I don't know if we have time for any questions. We don't, but we'll talk more in our breakouts. Thank you.
So we're doing pretty good on time here so far. I do want to say, if there's anyone in the audience who's a part of the Greater New Bedford community that is not a part of the task force, who thinks that their expertise, interest, or energy would be well served in the task force, please do not hesitate to register in the back with our staff there so that we have your name and contact information. We'd love to see you out at one of our meetings and on one of our subcommittees helping move this initiative forward. I'm going to move forward with the introduction of our panelists and then their presentations. I have a unique pleasure of introducing one of my previous commissioners working for the Department of Public Health. Cheryl Bartlett was my commissioner when I came in. And so Cheryl is an accomplished professional and over 35 years of leadership experience in nursing, healthcare administration, public health, and health policy positions. Throughout her nursing career, Cheryl's received national certification in 4 different nursing specialists: cardiac, dialysis, HIV/AIDS, and infection control. Ms. Bartlett was the founder and executive director of the Nantucket AIDS Network, and received state and national recognition for her community approach to prevention, education, case management, and clinical care for persons with HIV and AIDS and their families. She was recognized twice by the Massachusetts AIDS Action Committee as a hero in action and as an unsung hero in 1997 for her dedication and compassion in the fight against AIDS. In June of 2018, Cheryl received the Muse Shattuck Award for the Massachusetts Public Health Association for significant contributions to improving public health across the Commonwealth. Ms. Bartlett has served on numerous boards of nonprofit organizations to address homelessness, domestic violence, substance use, mental health, public health, and positive youth development. Currently, she serves on the boards for the Plymouth Peer Recovery Center, the Plymouth Area Coalition for Homeless, and the Massachusetts Health Policy Commission's Advisory Board, Commerce Choice, and South Coast Chamber of Commerce. She's been recognized by the Massachusetts Senate, House of Representatives, and Governor Patrick for her outstanding contributions and commitment to improving the health of residents across the state. Ms. Bartlett has held the elected and appointed positions in several communities in Massachusetts, including the Nantucket Board of Selectmen. Cheryl received her nursing training at Yale New Haven Hospital and graduated summa cum laude from Stonehill College in Healthcare Administration. So I'm going to do the bios for all the presenters so that they can come up and we can save some time. Sarah Ruiz, Director of Planning and Development, Massachusetts Department of Public Health, Bureau of Substance Addiction Services. Sarah Ruiz is the Director of Planning and Development for the Department of Public Health, Bureau of Substance Addiction Services. She has been with the Bureau for over 20 years and has been involved with the implementation of programming statewide on a broad range of topics from prevention, intervention, treatment, and recovery support services. She's overseen the naloxone distribution program and other opioid overdose prevention strategies statewide since 2007. Tina Los, thank you. Our Regional Project Coordinator for the Essex County Asset Builder Network. Tina currently works with 6 communities using a positive youth development approach to build supports for youth as part of the Essex County Asset Builder Network. She works with stakeholders, including local government, schools, law enforcement, and youth-serving agencies to find ways to create and sustain environments where youth can thrive. For the past 5 years, Tina has worked with local and regional substance use prevention coalitions with a focus on youth development. Her previous experience includes work in program implementation and evaluation and research on behavioral health technologies. So we'll have the presenters provide their presentations. We'll start with Sarah, and then with Tina, and with Cheryl. And presenters, when you're done, if you don't mind taking a seat on the stage when you're done. so that we can go roll right into our question and answer period afterwards. Okay, so without further ado, Ms. Sarah West.
Great. So this is like to the right, advance. Good morning, everybody. Hi, it's great to be here. It's really an honor to be a part of this summit with all of you in New Bedford. I've really appreciated any collaboration and opportunity I've had to work with folks in New Bedford over the years that we've been working on the opiate crisis. Really, we've been leaders in a compassionate approach to the work. We worked with the New Bedford Police Department as one of the first departments to carry nasal naloxone, and starting in around 2008, one of the really early adopters, and they were just great partners at that time. We've partnered with Seven Hills Behavioral Health just from the beginning in naloxone access, and really leading with a compassionate approach, which has informed our work at the Bureau and really something we've been able to carry to other parts of the state, so much of which started here in New Bedford. So I want to thank you for that and really, really appreciate all of you here and just that you put your hearts on the line every day for this work. In this panel, I understand my role is to talk about intervention and sort of harm reduction approaches. So I'm going to focus on that of all the things we could possibly talk about as far as the work happening at the Bureau of Substance Addiction Services. I'm going to focus on what it is to work with people who use drugs, taking a compassionate approach and honoring their self-direction and autonomy in a way that you've really led the way in the Commonwealth, that I want to encourage you to continue and talk about other options, other things we can work on together. One, that I appreciate. Thank you for Chief Cordero's remarks, and he said a lot of he already touched on many things that I want to talk about today. So I appreciate him really showing the leadership in the city for this work. One of the key areas that we've really worked on together statewide in terms of harm reduction, in terms of engaging people who use drugs statewide, is our overdose education naloxone distribution program. As I said, working with Seven Hills Behavioral Health has been a real pleasure in that for us at the department. I want to take the opportunity just to share some data from that program focused on New Bedford zip codes. So this is individuals who have been enrolled in the program with the New Bedford zip code. So this includes primarily the work of Seven Hills, but also any program in the state that encounters somebody, trains them in overdose prevention, naloxone, gives them a kit, enrolls them in our program, and has a New Bedford zip code. They're represented here. So we see that, over the course of the program, we're approaching 3,000 enrollments in the program, 2,899 total. And we've been running, you can see the growth in the program in recent years, just the hard work. Each one of these encounters is an opportunity to teach somebody overdose prevention, work with them on their plan for safety, and give them a naloxone kit. So we've had over, between 500 and 600 people, new individuals participating in the program each year recently from New Bedford. So the reach is impressive, and we appreciate the hard work that goes into that. In the program, we also get refill and rescue data. So when people are continuing to engage with the program, something we like to see, people coming back, working on an ongoing basis with the program, getting refills. And we see how that's increased over time, just the volume of work that's happening in New Bedford. And the red sections being the rescue reports that we've received. So when people come back and report using our naloxone, we're able to document an overdose rescue, and we've had, as you see, approximately 230 rescues per year in the last couple of years reported in New Bedford. So we know that that's an undercount in terms of those are the situations that have been reported to us. We know that there's so many more that happen, but still 230 years is an impressive number that have been documented. And that requires staff to sit with people, hear their story, right? Document it for us at the Commonwealth. We know and what a lot of compassion that requires in terms of working with people to discuss a traumatic event. And we really appreciate the heart that goes into working with celebrating people's rescues and documenting them for us, and that we're able to track that progress. I want to talk about what is a harm reduction approach. It is a strength-based, person-centered approach. It honors that person's self-direction, their autonomy, their dignity. What is it that they want to do? All of us are motivated by what is our own intrinsic motivation. What do we want to do? We don't want to be told what to do. And harm reduction honors that. What is their intrinsic motivation in terms of their health and their well-being? What's their plan, and supporting them in that any way we can. So that's the approach we want to use in the Commonwealth with people who are currently using drugs. They're at such high risk. But we have to be patient in our engagement process. Let them come back to us when they're ready. Let them direct their own path of their own plan and their own recovery. One area that I wanted to mention that we've been thinking about a lot is the safety of public bathrooms. We know from our data that really the majority of overdose deaths that in different studies and things we've tracked actually occur in private homes. So that's why the post-overdose follow-up work is so important, to reach people in their homes, in private homes, because there's nobody there to witness the overdose, to rescue that person. Using alone is a high risk. But for those overdoses that occur in public, a lot of them do happen in public restrooms. So we're trying to educate communities on looking at their public restrooms and their level of safety. How can we make them safe and welcoming places? Everybody needs a restroom to use. Speaking BioBot, talking about using the restroom. People need a safe space to be. It's dignified and humane to make sure there's safe public bathrooms, but that are also safe in terms of overdose risk. So we encourage you to look at the public bathrooms. Think about how can they be more safe. Do the doors open out? We hear stories of people blocking the door, you can't get in. You want the door, if it's possible, to open outward. You want to look at, for high-risk settings, such as health centers or hospitals, public spaces, libraries. Does it make sense to put in a motion detector and an alarm? Does it make sense to have other safety mechanisms in place? A sharps disposal, prevent needle stick injury so that needles can be safely disposed of. In this case, we see a program in Boston where they have the Narcan posted right outside the door. So in certain settings, that would be appropriate. And so let's think together as a community about having the bathrooms be as safe and welcoming as possible. We heard about bathroom safety. You see again, the difference of a door where you can see that somebody's down compared to a door where you can't. And think just these types of modifications that can really just enhance the safety. This is from this quote, and these images are from what we call the Rapid Assessment of Consumer Knowledge, the RAC study. And we funded a few of these now in the state. We're working with Dr. Tracy Green at Boston Medical Center, who does a rapid, meaning it's just a few weeks, an intensive sort of assessment of the community. And the good news is that we have on our plan for her to come to New Bedford. And to do a RAC study. So this is going to contribute, speaking of all the different assessment work that's happening, the strategic planning, the BioBot, all these elements, we're also going to have the opportunity to have a RAC. Now that is hearing from consumers directly. So this is a piece that I didn't hear mentioned so far in terms of an important source of information. The consumer experience, people who use drugs in the community, let's hear from them. So the RAC studies recruit people and have them do a quick survey and do some interviews in terms of their experience with access to clean syringes, their experience with access to Narcan, to treatment, their attitudes towards, the Good Samaritan law, calling the police, these types of things, just hearing from them directly, getting their feedback, learning about their experiences. We've learned in other communities where this is done, just areas for improvement. We did one in Lowell, and in the Lowell Lawrence area where there's been a very unfortunate outbreak of HIV. We saw firsthand about the issues of access to clean syringes and how important that is for reduction in HIV transmission. And with fentanyl in the heroin, the importance of the amount that people are needing to inject, the risks associated with multiple injections, it's so important for people to have access to clean syringes. That being said, we'll make sure Dr. Tracy Green partners with you, with the task force, on the implementation of this RAC study. So that will be an important component, I'm sure, for all of you to add to what's happening in terms of your assessments. Wanted to mention quickly some funding that we have in this area in terms of we have some large federal grants that have been coming into the Commonwealth with the generosity of the Substance Abuse and Mental Health Services Administration. With some large opioid response grants, what you call STR and SOR. Through those, we've been able to fund the post-overdose follow-up with first responder work, because we know that here we have a firefighter in Revere, but of course here the partnership with the police department. They've been really leaders in the Commonwealth in terms of the approach, as I was saying. Maintaining people's privacy. They don't come on the door and say, I'm looking for Sarah Ruiz. No, they say, we understand there's been, a 911 call in this area. Very, very private and respectful way of approaching with clergy. It are models that we have promoted in other parts of the state. We have coupled that really with increased access to naloxone distribution. These are, again, in partnership with the Seven Hills Behavioral Health, making sure that the outreach teams has naloxone available to them, and we've, through this funding, been able to increase the access to naloxone in this area. We see that as a critical aspect of our response to the opioid crisis. One thing I want to say about naloxone access is now, it's on us to be creative in how we continue to reach at-risk populations, people exiting incarceration, people that aren't accessing services in the same way. These overdoses that are occurring in private homes, how can we increase access to naloxone? Also, and we're seeing in the data, and so the commissioner coming in, that the commissioner will talk about how we're seeing co-occurrence of cocaine and opioids in our overdose data, and the importance of reaching people that use any type of illicit drug and how there's fentanyl in those. So really, whatever drug somebody's using, naloxone would be appropriate. And we need to think creatively on how to reach people who use crack cocaine, people who use methamphetamine as well with Narcan because of the contamination with fentanyl. Another program we have, and we have Rebecca Starr here, who coordinates this in the back for the Commonwealth, from Advocates for Human Potential. We have the ATR program, which is Access to Recovery. This is a voucher program that's to help support basic needs, as well as a career building initiative, which has been very popular in terms of supporting people to seek vocational training and pursue a career. That's now, we were able to extend that into New Bedford. And so we're building the program here. We ask you to partner with Rebecca on expanding what's available through ATR in New Bedford. We also have the Maytree program in Bristol County. That is a re-entry initiative that we're partnering with UMass on implementing the mission model in partnership with G.N.B Foundation, and we, through that, do intensive case management, access to medication-assisted treatment for people exiting incarceration. We're also working on implementing the CARE Act, which will provide medication behind the wall for people with opioid use disorder, continuing people's medication, not forcing a detox. Also, inducting people for their safety. There's such high risk on reentry. We want to encourage use of these life-saving medications. We want to reduce barriers to access to medication. It's a tremendous priority of the Bureau to think about what ways are we putting up barriers to access to medication and treatment, reducing stigma associated with using these medications, and encouraging access. We need to encourage people and congratulate them for accessing these life-saving medications. A couple of changes I want to make you aware of is, one is that we have now a statewide standing order that we've issued from the Department of Public Health for all pharmacies in the Commonwealth, signed by Dr. Alex Wally. So that covers all retail pharmacies in the Commonwealth. So anybody can get a prescription for naloxone at the pharmacy. So the pharmacies don't have to get their own standing order, their own prescriber. We have one that covers the whole Commonwealth. So that's a great step forward. We also now have access through our DPH bulk purchasing program for naloxone for DPH-funded treatment providers. They now are able to, this bulk purchasing program is available already to municipalities and to first responders. We encourage you to use the State Office of Pharmacy Services as a municipality, and now it's open to DPH-funded treatment providers to purchase in bulk. I'm running out of time. Wanted to say something about trauma-informed care, that anybody we're working with in this area is going to be somebody that's experienced trauma. The trauma of being somebody with an opioid use disorder, of witnessing, responding to overdoses. We talk about the number of overdoses and rescues. Each one is a traumatic event. For everybody who's experienced it, who's witnessed it, responded. And it's so important that we approach our work from a trauma-informed perspective, assuming trauma in the group, coming with a compassionate approach, taking care of each other in this work. This is difficult work. I respect and admire people on the front lines of this work, putting their hearts out every day with compassion. Part of that is celebrating the people's strengths, celebrating the victories, the lives saved. This is a board that's up in a program in Hyannis, the needle exchange and drop-in center in Hyannis, where they used to put up sort of memorials of people who died, and they said, no, let's celebrate the rescues. So this is where each time a participant has a rescue, they post it. They celebrate their survival, their saving lives. Let's focus on people's strengths and their survival and build their self-efficacy. I want to talk about the path to recovery is challenging. It calls on our better selves to really bring our compassion. But the definition of recovery is bringing somebody to improve their health and wellness and live a self-directed life. In order to build on that, we need to start now with people who use drugs, building their self-direction, having them take their own intrinsic motivation that will lead towards this pathway of recovery in a self-directed manner. It calls on us to be on our greater compassion in terms of this pathway and the challenges that it presents for all of us in the Commonwealth. I see how you do that here in New Bedford. I appreciate the patience and compassion with which you approach this work. And I believe that as we continue to support people down this complicated path, they will achieve their recovery. So thank you very much for having me here today.
We're going to go a little bit out of order, but I think we'll all enjoy this. Our commissioner is here, Dr. Monica Burrell. Dr. Burrell serves as the commissioner, the Commonwealth's chief physician. She's dedicated to reducing health disparities and developing data-driven, evidence-based solutions for keeping people healthy, and is helping lead the state's aggressive response to the opioid crisis. In 2017, Massachusetts was among few states to have a reduction in opioid overdose deaths, thanks to a variety of new programs and initiatives. As Commissioner, Dr. Burrell oversees a public health workforce of nearly 3,000, an expansive department addressing issues from environmental health to injury prevention to infectious disease. In 2017, Massachusetts was named the healthiest state in the nation by America's Health Rankings report. Dr. Burrell has practiced general internal medicine for more than 20 years and has been recognized for her dedication to underserved and vulnerable populations. Prior to becoming commissioner, she was Chief Medical Officer of Boston Health Care for the Homeless. She holds a Master of Public Health degree through the Commonwealth Fund, Harvard University's Fellowship, and a medical degree from the Boston University's School of Medicine. So please join me in welcoming Commissioner Dr. Monica Burrell.
Hello, good morning, everyone. Can you all hear me? This one, first test of the day, it's a trick. Can you hear me okay? Great. It's wonderful to be with you all today in this beautiful space. Jamon, thank you for that introduction. And it's always good to see you. As many of you know, he was with us at the Department of Public Health, and it is wonderful to be in a room again with former Commissioner Cheryl Bartlett. So thank you for having me here today and for all the work you've done for the department and for health in Massachusetts. And I'm thrilled to be following, even though unexpected, Sarah Ruiz, who has been a champion of this work for decades, and really fortunate to have her here at the department. And Sarah spoke about compassion and understanding and individuals celebrating moments of recovery. And that's what it's all about, and that's what this work is all about. And this really challenging work that many of us have been involved in for decades affects all of us. And nowadays, when I speak on this topic, I can't go to a room where people aren't professionally, personally, or otherwise afflicted by this awful epidemic. So I'm so pleased that you gathered here today. I hear about the work that you're doing, and it's really, really impressive and needed. And so what I'm gonna do now is I'm gonna take us to the 35,000-foot view. And I'm gonna talk a lot about numbers, and I'm gonna give you a sense of how we're looking at this epidemic from the state level to see if it's useful for you as you look at it at your level. I'll start with what I call my Department of Public Health house. So you can be grounded in some of the ways that we're looking at our work at the Mass Department of Public Health. Our vision and mission at the department remains the same. It's about allowing individuals to have access and opportunities for health. And what else would any of us want for our family and our friends? The foundation, that's the red at the bottom, that's about the people who do this work. It's the foundation of our work, and it's how we are able to accomplish anything we can accomplish for health in Massachusetts. And that's not only about the almost 3,000 unbelievably dedicated, smart individuals who work at the department, but it's about all of us across Massachusetts together doing the work of health. And the three columns in the middle is what I've added to the Department of Public Health and the way we think about our work. And that is about using the data that we have lots of pieces of data, and turning it into useful information and linking it to information that can help us understand better the social determinants of health, so how each individual community interacts with their health opportunities, and then understanding where the areas are where there are still disparities and still inequities, and targeting our resources to those areas so that we give all individuals an opportunity for health. You heard that in 2017, we were ranked the healthiest state in the nation. That's really impressive. And that is about really decades of really smart people, like the individuals in this room, doing work at the community maker level, making really smart health policy decisions. And for us as a community in Massachusetts, saying that we all deserve health. We deserve access to healthcare, and we deserve access to health in our communities. And because we demand health in Massachusetts, we remain one of the healthiest states in the country. And I do have to report in 2018, we did slip to number 2. Unfortunately, there was nowhere else to go. The state that beat us, which sometimes does, is Hawaii. You know, it's 40 degrees in the middle of April, so maybe they have that up on us. So I'm going to use this framework of looking at the data we have and really highlighting how we can best help individuals as I walk you through some of the ways we're currently looking at this opioid epidemic. So I'll start by sharing some of the latest opioid data. If you aren't aware of this, I hope that you will go to our Department of Public Health website or mass.gov/opioid response. And there you can find that every 3 months we put out reports that shows where we are in this opioid epidemic. It helps explain where people are dying from this devastating disease, and it breaks down the information by different communities. So I hope it will help you in your work, and I'll walk you through a little bit what our most recent report showed. So from our most recent report, this is what we'll see. So good news first. In the last 2 years, we're one of the few states that shows a real decrease, about 6% over the last 2 years, in opioid-related overdose deaths. There's a few things to note on this. We see this every day in our daily work, but you'll see that starting in around 2011 or so, we start to see this really devastating, uncomfortable rise in the number of individuals dying from opioid-related deaths. And that's what we are seeing visually in our communities every day. And as we top about 2000, you see that steep curve in 2011 to about 2014 area. That level of increase in deaths from any one disease, we haven't seen here in Massachusetts since the beginning of the HIV epidemic, before we had medications. And those of you who may have been working in these fields then, it was a devastating time. And this really heightened increase in deaths is what has called us all to action and continues us on this path. You'll see a little bit of red at the end of the graphs. We used to only be able to report this data with a 2-year lag. And as we know from our daily work, the opioid epidemic is changing almost daily, right? Monthly, every few months. So we put in place a predictive model. So it's a mathematical model that helps us predict whose deaths will have been later classified as from opioid overdoses in order to put this data out with a 3-month lag. I want to show the data to you this way as well. It's similar, but this looks at the rate. And for those of you who may follow other epidemics, when we see a disease epidemic, we sometimes expect to see that rapid increase and then a leveling off before we finally see a decrease. And what this shows us is that it's possible that in this current opioid epidemic, we're starting to see the leveling off period. It's possible, and we're hopeful that we are. And if that's true, then we hope to start seeing a steady decrease. But the other thing that this shows us is that it's really important that all of us together at every level, no matter where we're working, continue our efforts in this area full steam ahead. Because as I showed you on the last graph, we're still losing over 2,000 individuals a year from this epidemic. So there's a lot of work to do ahead, but we're tracking it very closely. I told you that now we put out information that goes with a 3-month lag. So in February, we released our data through December of 2018. And you can see the pattern of individuals who have died from this disease. And you'll see that at the end, just to emphasize that we do estimate those deaths. So at the end, if you look at our reports, you may see that the numbers change slightly. The reason for that is some of them are estimated deaths. So what's driving this increase, and what are we seeing here? Just to give you a flavor, and you can see any town or city. All cities and towns are reported in the opioid death report, the quarterly report. But what I show you here is the counts of overdose deaths in New Bedford. And as you can see, hopefully in New Bedford as well, we're starting to see that tapering off of the number of deaths. This data is broken down. It's another way of looking at it, which might interest you. The blue line is individuals who died who had a known residence here in New Bedford. And the red line is that the death occurred here, but they weren't necessarily from here. Several of the larger communities, cities, and other areas where there are a lot of services have asked us to break the data down in this way so you can understand for the individuals who are unfortunately losing their lives in that location, were they individuals who were coming for services who actually lived there? And you can see the differences here. So what's driving all of this deaths? And the really short answer is fentanyl. So as you all know, fentanyl is in the same class as heroin. Fentanyl is available on the streets of Massachusetts in every town and city around the state, and fentanyl is 50 to 100 times more potent and more deadly than heroin or other opiates. What these graphs here show you, we looked at individuals who had died, and at the time of autopsy, if they had an analysis done of what substances were in their system. And what we find here is that, see that dark blue line on the top that keeps rising? That's fentanyl. And we know now that in almost 90% of individuals at the time of death from an opioid-related death, fentanyl was present. So almost all deaths right now in Massachusetts that are opioid-related are related to fentanyl, and that big slope increase in the number of deaths is very much connected to the availability of fentanyl. The other interesting thing to note is if you look somewhere in the middle of 2015, you'll see that red line going down. That's heroin. So illicit heroin on the streets is now much less available. And even if individuals are looking to use heroin, it's really fentanyl that's available. And so that is part of the message about making sure that individuals understand the potency and the danger of fentanyl. The other thing I want to point out for you on this graph is you'll see some of the purplish line. That line is cocaine, which is still present. We don't talk as much about cocaine, but there's a lot of cocaine and amphetamines in general. The amphetamines alone, like methamphetamine, for example, is that orange line on the bottom, and you can see a slight increase. Those are on the rise. People are using more stimulants. The main message from this, though, is that this is still a disease with polysubstances. People are using many different substances, and we need to be aware of that. Talking about stimulants, I want you to be aware that we're starting to track that now. So stimulants, things like methamphetamine and cocaine, we're getting a lot of indications that the use is on the rise. It, as you know, didn't ever go away. But unfortunately, even in the opioid deaths, we're seeing more and more cocaine and methamphetamine use. So it's really important to be aware of that. We actually last year put out an advisory, a clinical advisory for individuals to understand that if someone believes they're buying illicitly cocaine, it may be laced with fentanyl, and for people to start to understand things like how to use Narcan, even if they don't think they're using fentanyl. And this shows here that we're seeing a rise in both groups. Males seem to have a higher rate of overdose deaths involving stimulants than females, but both are rising. So something for community and situational awareness. So what else can we learn from looking at the individuals who have lost their lives to this disease? What else can we learn to better understand those who are currently suffering from it and prevent further disease from opioid use disorder? Let me give you a few more things that we see. This shows that the overdose deaths are higher in males. So 3 out of 4 of the deaths are in males. That's interesting to me because oftentimes people are accessing services for opiates. It's about half-half, roughly, in many programs, but more men are dying from the disease. This here looks at the age of death. So if you look at the top bar, you'll see deaths from all causes in Massachusetts. And as you would fortunately see, most individuals, that dark maroon line, die at an older age. Unfortunately, the bottom line, which is opioid-related deaths, those deaths in that gray and dark gray, those are all individuals less than 44. So if you work in this area, you know this, but part of the devastation of this disease is it is taking people in the prime of their life, and we are really, really seeing a devastating amount of deaths in younger people. I'll note that you may have seen last year that Massachusetts has bucked the national trend, and our life expectancy has actually increased last year. So we're over 80 years is our average life expectancy. Again, most places in the U.S. are seeing a decrease in their life expectancy. You've probably read about that, and a lot of that is related to young people losing their life. In Massachusetts, because of management of chronic diseases and other access to care that we have here, our life expectancy is increasing, but it would actually be much higher if we didn't have all these deaths that we were having from the opioid epidemic. As I talked to you about data and how we look at data in different ways, we're trying to understand as much as we can from this data. And as part of that, we broke the data down for the first time, individuals who had died by race and ethnicity. And I'd like to share with you what we found. The first set of columns is individuals, all individuals. So remember I told you we're starting to see that decrease, right, in the deaths, thankfully, for all individuals. If you look at the second group of bars, that's individuals among us who are white, non-Hispanic, and thankfully we're seeing that number beginning to come down as well. If you look at the last set of bars, that's individuals who are Hispanic in our communities. And we were seeing a pretty rapid increase. You see that almost 100%, but thankfully that's starting to come down too. Unfortunately, what we found in this data is, look at that third group of bars, the only group among us in Massachusetts who is still seeing an increase in the rate of opiate deaths is Black non-Hispanics. And we broke that down further to try and understand it further. And we found, if you look at that circled line, the only group of individuals who still are seeing an increase in deaths are Black non-Hispanic males. So when we broke the data down, it really helped us understand things in ways we hadn't appreciated before. And this has allowed us to take some of our federal funding and direct it to communities of color and think a little bit differently about how we're making sure that our policies and programming are reaching all of us. So one of those examples of using data in important different ways. So that's our quarterly report, and I hope you'll take a look at it. The other piece of data I want to share with you is what we call Chapter 55. Chapter 55 is our public health data warehouse. And the reason it's called Chapter 55 is in order to understand this data and use it to help the opiate epidemic, we had to change the law. So we had to change the law called Chapter 55 in Massachusetts in order to bring data together and understand this opiate epidemic. A group of very wonderful epidemiologists at the Department of Public Health said, addiction has been around for as long as us humans have. And in this opiate epidemic, how do we look at the information we have and make sure we're being really evidence-based and data-driven as we move forward in trying to address this through a public health lens? So take a look at this. These buckets of information, it's pieces of information related to births in Massachusetts, deaths, what kind of prescriptions are in the system, what kind of services are used by the Bureau of Substance Addiction Services, it's jail and prisons data, it's Medicaid data, and so forth. And so what we did is we brought this data together and at an aggregate level, so at an overview level, said what can we learn from this and how does it help us understand the current opiate epidemic? We started doing this work in 2015. Because our funding that comes in for addiction services was going out to services, we developed private-public partnerships where universities, hospitals, others agree to help us understand this data better. Here's a short partial list of some of the partners who came together to help us and contribute their talents and capacities at data linkages and analysis to help us better understand what's happening in the current opiate epidemic. This data I'm going to show you is from 2011 to 2015. I share it with you because it's really helped us at the department understand how we need to advance our programs and policies, and I hope it will help you too. And other states around the country are looking at doing similar things as well. First, opioid use disorder prevalence. So that's basically how many of us have opioid use disorder in Massachusetts. Of those of us above age 11, it's 4.4%, and you can see that kind of sharp increase as the epidemic started. I've worked with individuals who have used different substances throughout my career, and I was surprised it was higher than I thought it would be. 4.4% of us with opioid use disorder. It's high, and it's actually at least double what we had predicted before. And why is it important we understand this? Well, if you think about it, with any disease, if you want to go and try and find everybody in a community who has diabetes so you can help them with healthy eating habits or who needs insulin or what medications they need, you kind of need to know how many people there are. With opioid use disorder, we really we're starting at a starting point where we didn't have a lot of information. So that's the opioid use disorder prevalence. This is what's called a survival curve. We use this for many diseases, such as, for example, cancers, to know when someone gets their diagnosis, how much time do they have before they die. In this case, we went backwards, and we said for all those individuals who died, and I showed you some of that data earlier, if you went back to their first prescription pill, which, as you know, is a big part of this current epidemic we're in, if you go back to that, how much time do they have to live? And from that first pill until they die, it's a very short 36 months. And this information, as devastating as it is, really helped when we're talking to our partners and even for ourselves and all of us in the room to say, we can't wait. This is not something that can wait until we have more funds or we have more people or we have a different plan or we figured this is a now thing. This is something that there are people who are at risk now, and we have to ask quickly. And this has really helped me with a lot of our partners to be able to quickly move forward in terms of acting now. And I see a couple of people taking photos, and I'll make sure these are available to you as well, so you can look at them in more detail. This is about medication. There's lots of data, that the 3 medications that are FDA approved to treat opioid use disorder work. This is data from here in Massachusetts. And what this shows us is, if you look at the individuals who come in with a non-fatal overdose, so they come to some kind of care, whether it's through the criminal justice system or through the medical system, or they're presenting and they had an overdose, and thankfully, thanks to the work that Sarah just presented to you and others, they had a non-fatal overdose. Those are the individuals who are at highest risk of having a fatal overdose. Makes sense. So if you look at those individuals and you looked at whether at the time that they presented, they received buprenorphine or methadone, what happened? And then you look at the curve, the bar on the right-hand side, that's if they didn't receive the medication. And what you see is that if they do receive the medication, their risk of dying goes down by 50%. 50%. So if you think about it, when you go and you ask your doctor, well, will this blood pressure medicine that I'm taking, or this diabetes medicine, or this cancer treatment, will it improve my likelihood of living by 50%? There's very few medicines that do that. But here we have medications that, if prescribed right and coupled with counseling and supportive services, saves lives. So when my clinical colleagues ask me, what can we do about the opiate epidemic? I point to this number. And for any of us who work with individuals with opioid use disorder, getting them access to treatment is really a critical part to saving their lives. I'm going to go through now and identify a couple of groups for you that we identified as highest risk for dying from opioid overdose. First, individuals with a history of incarceration. What we found that if individuals had a history of incarceration, either in prison or jail, remember how we linked all that different data together, they had 120-fold higher risk of dying from an overdose. And unfortunately, we saw that highest risk time is when they're first released. So it's in those 2 weeks when they're most vulnerable for having that overdose. And I see many of you nodding in the audience because, like myself, if you're in the field, you've seen that firsthand. What this data did for us is it really helped us with our criminal justice colleagues and opened up for the first time an opportunity to dialogue around medication when someone is incarcerated, continuing their medication, or at the time of discharge, having them have a connection to the community and be on medication. And you may have seen in the papers that the Department of Corrections, has started treatment for the first time, as our jail systems are also working on starting treatment for individuals for the first time. This is individuals with a history of homelessness. So housing instability is a risk factor for lots of health issues. But unfortunately, if someone's had even a short period of homelessness, their risk goes up substantially for an overdose. And one of the most important things in this area for me is that as we think about getting individuals these treatments I'm talking to, or opportunities for recovery, we can't ignore their housing status and making sure that they have a stable place to stay so that they can continue a successful recovery. Another high-risk group, again, if you're from the field, you know this already, is individuals with serious mental illness. Unfortunately, co-occurring or substance use disorder and mental illness is extremely common. And SMI here, that second orange line, that's serious mental health issues, that's things like psychosis and schizophrenia, that really increases your risk. But look at the depression line. Even bread and butter depression, which so many of us suffer from, can increase the risk of overdose. So making sure at the state level, we're doing a lot of work. You may have seen we recently opened up some more co-occurring beds for residential recovery. So making sure individuals get both things treated is really important for some of our work we're doing at the state level. The final high-risk group I want to point out is pregnant and postpartum women. If you look here, this is, again, data from that data set I told you about. So look at 1 year before delivery, a woman with opioid use disorder. So that's kind of her baseline risk for an overdose. And you see, I don't know, maybe it seems intuitive, as the pregnancy progresses, her risk for overdose goes down. And then after delivery, and many of us have seen this, the risk goes up. However, many of us were surprised to see that the highest risk for overdose for these women is in fact in the 6 months to 12 months after delivery. And many of our programs, really inadvertently, not knowing this fact, we're stopping after the first couple of weeks or months. And what we've done now is really pointed this out to our programs and worked with the folks who do programming with mothers to make sure that programs continue to 6 to 12 months, because that's when they're at highest risk. I always get a question on this where individuals ask me, well, are these moms who stayed with their babies or didn't, or what else can you tell me about this? And we don't, that's the next level of detail that we're working on now. But this has really helped us in our programming and policies to how we think about this group of high-risk women. So that's just a sampling of the data. I'm gonna take just a minute more. No one's giving me any time thing, so I'll just keep going until you guys seem to get bored of me. But I'm just going to give you a whirlwind tour of, oh, there you go, thank you. So in my 1 minute, I'll give you a whirlwind tour of some of the governor's opioid working group principles. So I spoke about looking at this epidemic through a public health lens, and that means focusing on prevention, whether it's primary prevention with our children who haven't yet been exposed to opioids, or intervention such as what Sarah so eloquently spoke about earlier, making sure that individuals at risk have access to services, and then making sure we have enough treatment and recovery. And we're on a journey with this. If you look up the opioid working group, you'll see that there's over 60 recommendations, and all of them are in implementation mode. So talking briefly about prevention. This campaign is called State Without Stigma. The most important thing I want you to know about this is, you probably see this in your work too, but stigma is still a real issue for this. I keep talking about this as the medical disease that it is. People still see it as an issue of choice. People still see medication-assisted treatment as, a crutch from one med to another. And we don't speak that way about things like diabetes and insulin treatment. So there's a lot to do still in this area for each one of us individually, as well as for our communities. Parents came to us a lot and said, if you're a parent in the room, I have teens and I know this comes up all the time. Well, we didn't think to talk about pills and prescription pills, and what about fentanyl? How do we talk to our parents? So we launched a parent campaign that talks about how to talk to your children in middle school and high school about the opiate epidemic. You can find this online, and I hope you find it useful. There's been a lot of work done safe prescribing, changing the way we think of opiates for pain, including a 7-day limit, including having to check the prescription monitoring system, and doing prescriber education, including we were the first state to put in place voluntarily by all the schools a requirement where they teach at, you'll see all the schools listed there, they teach about the need for pain management, but how to balance that with the potential for opiate misuse. So that's done in all schools across Massachusetts for prescribers and social work programs. We're seeing results from that. The blue line is a decrease in prescription opioids in our communities, over 30%. And that corresponds to the green line being use of the prescription monitoring program. So we're starting to see results in this area. And people always say, well, is it the right people that aren't getting the opioids and the right people who need it getting it. And that is a balance that I think is still working out. But this shows that individuals of concern, so areas where you may have said somebody might be doctor shopping, if you will, that is also going down as the prescription monitoring program is being used more. I won't talk much about naloxone, as Sarah covered this so well, but it's really a key part to our program. And first responders have been just tremendous in Massachusetts, making sure that access is there. In treatment and recovery, we've had since 2015 over 1,000 more treatment beds. It's still not treatment on demand as we all would like, and it still doesn't mirror other diseases in our system, such as, again, diabetes care or heart conditions care, but we're moving in the right direction in this area and expanding treatment for high-risk groups, as I gave you examples of. I want to urge you, if any of you haven't gone to our helpline recently, to check it out. I used to use it all the time in my clinical work. And what we've done now is there's several new and important features, including a live chat that can help individuals navigate the system, a way for providers to use it, as well as clients, so that people can get the kind of navigated help they need. And now it's also 100% available in Spanish. I mentioned recovery before, and we're doing a lot of work with recovery coaches, recovery support centers, really recognizing that for all of us, treatment of this very challenging disease is not just about the medications or the counseling or the access to detox, but it's about building a journey to recovery where we have purpose and meaning and capacity to work and be with our families. So it's a really important part of our work. Here's some ways to be in touch with us, and I thank you all for having me here today and for all the work that you do.
Thank you, thank you, thank you. We'd like to continue. We're trying to stay on time and on task. We're just about halfway through the program this morning. I'd like to take this time to introduce our next presenter, Ms. Cheryl Bartlett. She, again, is one of my previous commissioners. Sure.
Thank you. Good morning, and thank you. Oops, is this, hello? It's on? Can you hear it? Okay, great. Thank you. Thank you, Damone. It's off. I shut it off? No. Okay. Is that better? No. No, it's on. Okay. There we go. Great. Thank you, Damone, and thank you, Chief Cordera, for your leadership at the Opioid Task Force and all the other things that you do here in the city of New Bedford. It's really refreshing to see a group of community members coming together to have these conversations. Because as the commissioner noted, that prior to 2011, when we saw the significant spike in opioid deaths, we really didn't talk about substance use all that much in our communities. And I can remember in the days of HIV and AIDS, when half of our patients were being infected with HIV because of substance use, these were conversations that communities didn't engage in. So it took this radical increase for us to come together and be able to talk about it. So it's exciting to be here today and to learn so much, a lot of interesting new information today. And happy to be part of this. So I'm going to talk to you a little bit more in depth about the treatment of opioid use disorders. And as several of our speakers have noted, that addiction really is a medical disease and that it's progressive, which means that without treatment, it will get worse over time. It's chronic, meaning it can't really be cured, but it can be sent into remission with appropriate treatment. And relapsing mean that we should expect that our patients will have periods of relapse and recovery, just like any other chronic disease. This disease of addiction is very similar to diabetes, asthma, high blood pressure. These diseases all have relapse rates of about 40 to 60%. And we don't criticize and blame patients when they splurge on some sugar and have some kind of a diabetic episode that takes them to the emergency room. But when people have addiction and they relapse and they come in for treatment, oftentimes they're punished. And so it's really important for us to liken this to the way we treat other patients with chronic progressive relapsing diseases. And all of them have similar risk factors. Research points to addiction as a medical disorder rather than a moral failing, a character weakness. And just like these other chronic diseases I mentioned, there are underlying risk factors and causes. There's genetic predisposition. There's some data that would show us that about 20 to 25% of people have a genetic predisposition for an addiction. That we make unhealthy lifestyle choices, just like we do with heart disease and obesity and diabetes. That there are environmental factors that influence what happens in our lives and the choices that we make, and there are biological factors. And many people with addiction experience root causes such as stress, family histories of substance use, trauma and abuse, co-occurring mental illness, and family dysfunction. And many times people self-medicate by using drugs and alcohol. And what happens with opioid use is that it basically changes how our brain is wired. And heavy substance use causes the brain's natural reward circuit to get hijacked by the extreme euphoria that opioids produce, which overrides our normal dopamine system in our brain that gives us pleasure. And once your brain is hijacked by opioids, you need opioids just to function. Very soon after people start using, and we saw how soon people can go to death with using opioids, very soon the brain can be addicted and hijacked, and the only pleasure that a person gets is to take the drug. And actually it does get to a point that they need to take the drug just to function. Many people can't get out of bed because they can't function without that opioid stimulation that they get from taking the drugs. So anyway, this creates a really powerful craving and a conditioned response that leads to their compulsive drug seeking and taking behaviors. And according to SAMHSA, which you've heard some information about SAMHSA, that's the Substance Abuse and Mental Health Services Administration, there are many pathways to treatment, but most of the evidence points to medication treatment as being the most effective for keeping people in long-term recovery. I think some of the statistics that I've read are that about 85% of people with an opioid use disorder will relapse if they don't use some kind of medication maintenance to help them on their path to recovery. Treatment with medications block the effects of opioids, and it reduces the cravings, it prevents the symptoms of withdrawal, and it helps to restore somewhat of a normal brain function. Removing cravings and withdrawal symptoms allows the individual to rebuild their lives. Many times by the time someone's addicted to opioids, they've had family issues, they may be estranged from their families, they have been unable to maintain employment, and in general have a very unstable lifestyle. And many people have been able to rebuild their lives by taking long-term medication treatment. And I know we call it medication-assisted treatment, but I think that that's just another part of how we differentiate this from other diseases. We don't say a diabetic taking insulin is on medication-assisted treatment. We say they're on medication being treated for their diabetes. So I like to refer to this as medication treatment. There are 3 medications that are approved by the FDA for treatment of addiction. Methadone, which has been around the longest since 1971. And methadone is a very highly regulated drug. It's administered in opioid treatment programs that are certified by SAMHSA and registered with the Drug Enforcement Administration. Usually requires a person to make daily visits to a methadone clinic where they have observed administration of their medication. And along with that, they get counseling and other psychosocial support services. In some cases, the federal law does allow people to get what's known as take-home, and I hate to say, I'm hoping maybe it's different, but I know Massachusetts has been one of the more restrictive states in terms of how much take-home we allow patients to have. But when people are in stable recovery, people can take the medication home for sometimes up to several weeks and then come back into the treatment center. And that's important because in my mind, having gone to a methadone clinic, I think if I was living with an addiction, I would struggle to have to every single day get up and go to a clinic before I tried to get myself to work or my family off to do the business of the day. So it really restricts the lifestyle. And if we're trying to get people back into a normal rhythm of their life with purpose and jobs or education or family life, that having to go to a clinic every single day, I think, is a barrier for some people. But for some people, it actually works because it replaces the daily getting up and craving the drug and going out on drug-seeking behaviors. But anyway, we have quite a few methadone programs. When I was at the Department of Health, I believe there were about 18,000 people that were using methadone here in the state of Massachusetts. So they are an important choice for people to make in medication treatment. Buprenorphine, or better known as Suboxone, has been around since about 2002 for the use of treating opioid use disorders. It's prescribed by doctors, nurse practitioners, or physician's assistants who have gone on to get more advanced training and gotten certified and allowed to prescribe this. Again, no other drug to treat other diseases do you have to go and take special training after you get out of school to be able to prescribe it. So that has become a barrier. Only 5% of providers that are able to prescribe this medication do because of some of these barriers, and that's not the only barrier to it, but sometimes they're afraid to become a prescriber because they may be the only person in a community or within a practice, and they feel like they'll be overwhelmed by that. There also is a limit on the number that an individual can provide prescriptions for based on their credentials and their experience. But this is a better form, I think, of medication treatment because it's an office-based addiction treatment. You can go into your primary care provider if they choose to become waivered and get your treatment right there as part of your overall holistic care. And your primary care providers usually know you the best and have the most influence on helping you try to move into a healthier lifestyle. And then the third one is naltrexone, or better known as Vivitrol. It comes in an oral and injectable form. The oral form isn't that effective because you have to take it every day and adherence to it is poor. Vivitrol is a shot once every 30 days, and that has worked for some people, but for some people, I've heard that they begin to have cravings at day 28 or when they're approaching that 30-day, and so they've figured out how to use at the end of their Vivitrol dosing and then go back onto it. So I personally haven't seen the great success that I've seen with some of the two other medications. As Dr. Burrell noted, it does reduce mortality by 50%. It's effective, it's safe, particularly when it's used in combination of psychosocial support and counseling services. And many people think that we need to have the goal being getting people completely off eventually of medication treatment. And I think that what we want to do is, like we do with any other treatment, it's individualized. If the person can get off the drug, that would be great. It'd be great if no one took drugs for anything and we were all just healthy all of the time. But I know people that have been on methadone for 25 or 30 years, and they get criticized every year by their doctor for not trying to get off of it. And I have this one woman I helped on Nantucket 25 years ago, and I know the doctor, so she'll call me and say she's yelling at me again. And every time I even think about wanting to get off of it, I start getting cravings and wanting to use again. So I don't think that that should be our goal for everybody. I think we need to individualize our care. The pros of medication treatment are that there's an abundance of evidence that it's effective, despite what the stigmas are around it. People with the disease are stigmatized, but people that take a medication to maintain their recovery are stigmatized, I think, even worse. There are some peer support groups, NA and AA groups, that won't let you into their group or won't let you speak if you're at their group because they don't consider you to be in recovery if you're taking a medication to help to treat your medical disease. And I think that that's unfortunate. But there are more groups that are breaking off and forming support groups for people that use this as a method of being in recovery. It decreases mortality, it decreases co-occurring infectious diseases, HIV, hepatitis C. It decreases relapse. It decreases criminal behavior. This is probably one of the most significant factors, is that about 85% of people in our prisons are there for drug-related crimes, and it's great to know that we're in a city where we're looking at diverting people who are maybe committing minor crimes that are related to their drug use, and we are trying to help divert them and keeping them out of the criminal system, because this will just help them, again, to rebuild their life, to have employment, and to have meaningful relationships. And it also helps with family function. I've seen families torn apart that after years of medication-assisted treatment and the person rebuilding their lives, their families come back together again. Unfortunately, it's not widely available. Across the nation, I think it's only about 11% of programs offer medication treatment as one of the pathways to recovery. In Massachusetts, it looks like it's up to maybe about 23%, but that still is unfortunate that some people aren't even given that option. With any other disease, again, we would probably lay out all the options and help the person make the best decision for them and their families. I'm proud to say that the Greater New Bedford Community Health Center has moved into medication treatment about a year and a half ago. We got a federal grant, and we are beginning to prescribe buprenorphine to our patients. We did an analysis of the patients that come to the health center. We serve about 25% of the city's population here, 25,000 patients a year. And when we looked at in our medical records, about 1,700 of our patients received some kind of medication. About 1,000 of them were methadone, and about 700 of them were buprenorphine, which means they had to go somewhere outside of the health center to get that care, in addition to the care that they get from us. So about half of our providers now are prescribers, waiver to write prescriptions for buprenorphine. I have some of my colleagues I want to shout out. I have Paul Cassidy here with us today. He's the newly appointed Director of Behavioral Health as we begin to move down the path of integrating behavioral health into our services. Paul's probably well known to all of you in the world of HIV and AIDS and infectious diseases. And then Mary Kanya, who was our first program coordinator to help kick off the OBAT program here at the Greater New Bedford. And our goal is to really make this be part of primary care, where doctors and nurses are comfortable treating all of the elements of a person's health and that they can get their prescriptions there. We do counseling on site. I got to corner the commissioner, Paul, to tell her our application was coming in for our mental health license from DPH, and also the Bureau of Substance Addiction Services. So hopefully they'll help us move that along so that we can continue to grow our behavioral health services. So again, thanks for including me in today's conversation and discussion. It's great to have so many people here, because this is a sign that we can really continue to improve what's happening here in New Bedford. Thank you.
Thank you, Cheryl. And I'll be happy to, when we're able to have the next summit around long-term recovery for our clients. And that'll be a very nice conversation to have. Tina?
Well, I guess that's what we said. I don't know what happened. Hi, everyone. My name is Tina Lose, and I'm here today with the Essex County Asset Builder Network. Thank you so much for inviting me to speak with you, and I'll keep my comments brief as I know we're kind of short on time. But I wanted today to bring a message of hope to the summit. And a lot of the work that we've been talking about today around the opioid epidemic can be really daunting. And we know that this is a really big hill that we're trying to climb. And the work that I'm doing right now is I see as an opportunity to help young people make healthy choices before they even have an opportunity to make a bad one. And that's what makes me really passionate about the work that I do. So just a brief history, I used to work for the Gloucester Health Health Department and on their Substance Use Prevention Coalition. And a lot of the work we had done was when the Angel program was launched. And so a lot of it was opioid and treatment and recovery focused. And my job specifically was working with youth around substance use prevention. And a lot of the work we did was very focused on how can we get kids to stop vaping, stop drinking, stop using drugs. And while that was important, it felt to me that it wasn't enough. And so in this new position, we use a model, it's called positive youth development, that I'll talk about in a little bit. But it really allows us to engage with youth in a meaningful way and to have youth feel like they have a voice and have a purpose. And we know that that makes them have healthier choices. And so for me personally, it really brings a lot of, allows me to bring a lot of passion to the work that I do and feel like I'm making a positive impact in the community. And I think that's so important as we continue to fight this opioid epidemic. And it's such a long road and it's hard. And a lot of times there's this burnout and this feeling that we are trying to make things better and it's just taking way longer than we think it should. And so this approach really has helped me find a way to feel like my work is impactful and meaningful. So just to kind of give you a sense of where I'm starting from, we've talked about this, a few of our presenters have brought it up already, the continuum of prevention. And when I think about prevention, what I'm really thinking about is that we already have identified a risky behavior or a substance that we're trying to get youth to not use. And where I'm coming from is health promotion. So we're taking a step even further upstream. So we're saying before we even are trying to get the kids not to fall over the cliff, we're saying how are we supporting the kids to teach them how to swim so that they can keep going and never even have to worry about falling over the edge. So there's a lot of buzzwords going around right now, resilience, protective factors, positive youth development. But what all of these things have in common is that if we think about packing a bag for youth, we want to stuff it with as many skills and relationships and qualities and positive characteristics and feeling of self-importance and resilience that we can give these youth so that no matter what happens in their life, that they have tools that they can pull from and they have supports and people in the community that they know and trust. And we know that that's really important for building up healthy youth. So the Essex County Asset Builder Network is a group of 6 communities who welcome, value, and empower youth through meaningful opportunities and collaborative efforts, and that's really important. And we're trying to work to support and strengthen youth and their assets and increase their healthy decision making. A couple of points I want to make on these core principles that we use, and a few of these have been brought up by other speakers previously today. So our work is data driven. We find that that's really important, and we survey our students every 2 years to find out what strengths they already have and what are some areas that we can grow and help support those strengths, but where are they maybe lacking some of those strengths and where can we build? And the other piece that it sounds like you guys really have nailed down here in New Bedford is this community-wide approach. You have the right people at the table and you're working together and you're constantly asking who else's voice is not being heard. And that's something in my work working with youth that I'm constantly asking people is, if we're trying to work with youth, where are the youth? Where is their voice? Are they being engaged? Do they have a meaningful opportunity to contribute to the work? And if that's not the answer, then we're not doing our work correctly. So a couple of the core principles, if you think about it like an umbrella, positive youth development is an approach that we use in all the work that we do. And down here on the left, you'll see some typical things that we hear of when we think of traditional prevention approaches. So a lot of times it's fixing a problem or it's reactive. Something negative happened to the community. There was a death, there was an overdose, there was a suicide. What are we doing to stop more of those from happening, right? That's the theme that I'm hearing here today. We think about youth as at risk, so at risk for an opioid overdose, at risk for using substances. And many times it's adults in the room trying to come up with solutions to help the kids, and the kids are nowhere to be seen. The schools often also carry the burden of this, and it sounds like you guys really don't have this problem here, which is awesome, but we really need to be expanding the thought around what players are in the room and who could be helping, because a lot of times when you bring in new voices, you come up with really creative and diverse solutions to problems. So when we talk about the positive youth development approach, like I said, we're building on strengths and our focus is positive outcomes. Instead of worrying about which health behavior we're trying to mitigate, we're working on building up those positive outcomes. We want to see more kids making healthy choices. our approach allows us to be proactive, and this is really big piece of the work, is that we can start building supports and skills and resilience for our youth before we ever are concerned about what trouble they're getting into down the road. And this allows us to build positive adult relationships with the youth at much younger ages. So if you're saying, well, what's the earliest age you can start talking to kids about opioid use, right? You know, anything lower than 6th grade and people start getting cringy. But if you're talking about how we can give kids skills to make a positive choice or learn how to build those social skills with their peers, you can do that at a lot lower age. Again, it's for all youth. So we're not talking about just those at-risk kids, however you're defining at-risk, but we're saying that all youth at some point are at risk for some risky behavior, whether they're home alone all day because their parents out working 3 jobs, or they're home alone all day because their parents working in Boston and they're working 80-hour weeks. Those youth are still at home alone. Again, youth are active participants. It involves the whole community, and there's the focus on environmental and policy change that are affecting more youth at once. So if the positive youth development approach is our kind of umbrella term that we're using, the 40 developmental assets is the framework that we use at the Essex County Asset Builder Network and in the greater Newburyport communities. And it's a set of qualities, experiences, and relationships that we know make youth have healthy choices. The developmental assets were created by the Search Institute. They've been doing research on these assets for over 25 years. And they're broken into external assets that are focused on more of how the community is supporting youth, and internal assets that are focused on what the youth have themselves. So that sense of identity, confidence, sense of purpose, sense that they're a valued member of the community. And the biggest thing that we know about this research is that the more assets youth have, the less high-risk behaviors they participate in across the board. That's the take-home message. So this is what allows us to keep working on those health promotion bits, and we don't have to worry so much about which risk behavior we're targeting, because we know that building youth up and giving them more of those 40 assets is going to help them no matter what the risk. So this is just a quick snapshot of some of the data. You'll see along the bottom we have asset categories, so youth who have 0 to 10 assets, all the way to youth who have up to 40 assets. And we're looking here at some of those thriving indicators. So how do we know youth are succeeding? And you'll see that the more assets youth have, the more likely they are to have some of those succeeding behaviors, such as doing well in school, valuing diversity, and exhibiting leadership. The opposite is also true. So again, those assets along the bottom, the youth who have those 0 to 10 assets are way more likely to be engaging in problem alcohol use, violence, and marijuana use. The youth who have over 20 assets, that's kind of our gold spot. You'll see that over 20 youth are only participating in 1 or 2 of those risk behaviors, rather than the higher percentage with lower assets. I've covered some of this, so I'm going to skip ahead. I want to give you guys a couple examples. And so thinking about that positive youth development approach, like I said, it's for all youth. Youth are engaged, and the entire community is present. And those are the 3 of the main keys that I want to focus on. And I want to talk to you about this as an approach, and it's how we're looking at the problem. So if we look at this picture really quick, do you guys see a rabbit or do you see a duck? What comes up to you first, right? And so what you see is the lens that you come into this work with. And what we're asking you to do is, instead of looking at that lens and saying, what's the risk that we're trying to prevent? We're asking you to switch your intent and think about why we're doing the work and what our outcomes are. And the work itself doesn't have to change, but the why does. And that's kind of how we can all incorporate this approach into our work. So I'm gonna give you 2 quick examples. So like I mentioned, I've been doing this work for about 5 years now. I've done a risk-focused approach and a positive outcomes-focused approach. And you can use this positive youth development model no matter which focus you're using. So for our risk focus, we were looking at reducing youth access to alcohol. So we engaged youth. We asked them to be the ones to look at their own data and tell us what they saw. They realized that youth weren't buying alcohol from the stores directly. They were, or parents weren't the ones mostly supplying. Youth were getting alcohol from their older brothers and sisters and their friends who were coming back from college. And so it was all about a who you know approach. So how do you get messaging out to those people that it's not okay for them to be giving alcohol? You can't send out like an all-parent call through the schools, right? That 18 to 24 group where youth were accessing their alcohol is really hard to kind of get a hold of. So the youth got together, they were trained in how to run focus groups, and they talked to that 18 to 24 population and said, what messaging do you guys use? Like, where can you get your tool, or where do you hear messages? What are your thoughts about giving alcohol to your younger siblings? Do you think it's okay? And they got some of that information from our source group. Then together, the youth were able to come up with this campaign. So what you'll see on the right-hand side are coasters that we created, like bar coasters. So we went to local businesses in town and asked them to give out these coasters that have information about giving out the penalties for giving alcohol to underage youth. And we put these out on Thanks Drinking Eve, so the biggest bar night for college people when they're coming back. And, you know, they're just sitting around. We met the engaged population where we knew they would be, and we were able to engage the whole community in this way. So it's a positive youth development approach. We engaged our youth, we engaged the whole community, but we did it with a risk focus. Another quick example, so this is a positive focus. Like I said before, the assets that we're building, we know that if we build assets, the risk behaviors go down. So we don't even have to focus on the risk behaviors themselves. Here we're working with a group in Amesbury to increase youth connection to the community. We have a coalition where youth and adults sit together at the table. And we realized that youth felt like they didn't know that there were opportunities in town for them to get jobs or internships or volunteer. And the businesses in town were saying, we have all these jobs and opportunities and the kids just don't know, like they're not coming in the door. And so there was this disconnect. And so what we were able to do was work together to create an opportunity. We're doing a college fair, or career fair for these youth. And again, these three principles of positive youth development are at play. It's for all youth. Youth are active participants in thinking about who we want at the table and who we want to see, and the whole community is involved. So we're coming to the youth at the school. They'll have the opportunity to engage with the local businesses, and they don't have to kind of go out of their way. And so what I'm really hoping that you get out of this is that these are tools that you all can be using in the work that you're doing. And as you're thinking about your strategic plans and working on that process together, even today as we go into our next brainstorming sessions, I encourage you to think about how you can take these principles and use it in the work that you're doing, and really thinking about that next generation and how we can, jump ahead to try and make some positive outcomes down the road. Thank you.
Thank you, Tina. May I ask the presenters to come to the stage, please? I know you've all been sitting patiently for quite a while, so this is an opportunity now for you to kind of engage with the presenters. We have approximately about 10 to 15 minutes for Q&A. So, Carl, if you don't mind. Sure.
Great. Well, thank you all for doing such a great job with your presentations today. Another round of applause for our. I'm really, there we go. I really am thrilled that we're able to do this today, because it's exciting to see so many colleagues and some new faces that I don't know in this room, but it does take an entire community. If we take a look at everybody in the room, from outreach and folks in recovery, medical professions, law enforcement, criminal justice, child protection, we're all here. Take a look around. Take a look around the room. This is the network that's doing it on a daily basis. So give yourselves a round of applause, right? So now we've got 10 minutes to ask all the questions that we have in our mind. Take all the time you need, right? But there's a lot to be done in this 4-hour segment. So does anybody have any questions off that they'd like to bring up first? Yes, Kim, thanks.
Question for Cheryl. With the behavioral health expansion at the Greater Bedford Health Community Health Center, are we targeting all? Are we looking at youth? Are we looking at adults? Will it be...
Our goal is ultimately all, but we're probably going to start with pediatrics because we have an opportunity. Well, we hopefully will be getting a grant that can help us develop the capacity, and that will help us then be able to spread it across the health center. So we're trying to develop the billing capacity so it will ultimately sustain itself beyond grant funding.
Right in
There we go. Beyond the magic solution, beyond grant funding, right?
I work for the school department. So. Pediatrics is what I was looking for.
Okay.
Special shout out to Sarah, and because she's been helping us along our way with Connie's team at Seven Hills and beyond that. What do you see as the future for the work that you're doing as we're going? You mentioned about safe bathrooms and those kinds of things. If you could just speak into the microphone.
When in some of the invitation to us, they said, "Oh, do a TED Talk like presentation." So at work, they said, "Oh, start with the word imagine." Okay. Imagine a world in which where substance use is treated like any other medical condition. If there's not the stigma, there's open access to treatment integrated with their mental health, with their physical health. People are treated with dignity, just like any other person. That there's access to life-saving medications, housing, support, that people aren't criminalized, stigmatized, but they're supported in their health and recovery with dignity. And the ways that we can do that, I think, is increasing the access with programs like Cheryl described, with building on the assets like Tina described. I think these are steps towards building towards that future. We're working together to fight that stigma, to open the access, to work within ourselves in terms of what do we need to check at the door in order to, as a community, to make that future possible.
Thank you very much, Sarah. Questions? Yeah, Joe? Joe? Sorry about that. I gotta put in a shameless plug, but do go ahead. Yeah. Sorry.
I guess my question is to Sarah, because I've heard a lot about the stigma. I've heard a lot about the agencies. I work for the Department of Children and Families, and we do child protection, and as was brought up by the person who presented for IVOC, one of the deterrents is that people don't want to come forward is because they're afraid of losing their children. But I don't see where the Department of Children and Families is pulled in to work with, so develop policies, because we have the golden ticket as to why a motivation, why somebody would want to get treatment. And I know the stigma is, I know we're not popular, I know we're the enemy, but the department is changing its policies and procedures and moving in that direction to want to help, but they're always afraid. So how do we make that connection to overcome that barrier?
And I appreciate that. We have had some regional collaborations, and I believe there has been some in the Southeast and Western Mass, where we come to providers with DCF, with providers working with families, communicating together. There's got to be cross collaboration in terms of partnerships on supporting families. And so I think that is the way we're going to be able to look at child protection, but also supporting families to stay together, using that intrinsic motivation of parenthood to support recovery, not disrupting that bond with the infant and the mother. How important that is. Talking about the next generation, disrupting the bond for the infant and the mother is extraordinarily traumatic even for a newborn. So how important that is that we make every effort to sustain that bond and support family unity and unification. But that takes a village. I mean, that family needs a lot of support. That mom, we have something called the Moms Do Care, which is working with supporting moms with opioid use disorder through the process and postpartum. Now, this data around at 6 months, there's a drop-off. We've seen that in multiple places. So lately I keep thinking, that 6-month mark is something we all need to be thinking about. People in early recovery, we had a presentation from Dr. John Kelly at the recovery he researches recovery at Mass General Hospital, and he talked about in early recovery that there's this drop off at 6 months that they see. And then we look again at the data for pregnant women, and look at our programming, think about that's actually a critical moment that we all need to sort of wrap around somebody, that 6 month mark. So including families, women that are postpartum, and yes, we want to partner at the local level with DCF as much as possible.
Okay. Other questions? Yes, sir.
This is particularly for Cheryl because of your understanding of the hospital network and the insurance network, but I'm curious about the burden that the opioid epidemic places on this industry and how we might be able to get them involved in helping to solve it.
That's a good question. Depending on which care institution you're talking about, it's a huge burden. If you look at inpatient hospitalizations, that people that use substances and or have co-occurring mental health disorders have longer lengths of stay. So it's more costly for hospitals, and they're being incentivized now to have shorter lengths of stay. So that should be helpful in moving them that way. But we're in a system in the United States that's a sick care system. 96% of our dollars are spent on sick care, not on health promotion. And we seem to keep staying in that system of care. And I think we need to really start thinking about health promotion from birth through death, and that we need to, I think, put a whole lot more into our kids and our school systems. And our school systems, I think, are weary because we're putting the burdens of society into the school system in addition to their job of academic achievement. And I think we need to, if I had more time left in my life, I would totally revamp our school systems and make them community centers where kids could be all day and get education, get help with homework, have sports and recreation. Parents wouldn't have to be hassled with where do they bring them before school, how do they get them from preschool to school to after school care. I don't think our school systems have kept up with the way society is today. And to make a healthier generation, we need to, I think, really invest more. But we're so burdened with the disease end of this that our resources continue to get sucked up in. I don't know how you get out of that. I think that hospital and health systems have a lot of fixed costs. They have big buildings, and I don't think anyone has thought about strategically what do you do with those if you have people not in the hospital as much. And I'd argue we could repurpose them to bring the non-for-profits in our communities on the campuses of our hospitals and healthcare systems, because those are the organizations that often address the social determinants of health. And having lived in the not-for-profit world my whole life, I've always been scrambling to be able to afford to find a place to do the work that we do. So how do we bring that all together? And we tried to do that here in Massachusetts with the Prevention and Wellness Trust Fund that we had for 4 years. And the unfortunately legislature didn't continue to fund that, where it was a bringing together of a municipality, a hospital/health system, and the community-based organizations to really look at a healthy community approach when we needed to have health and health policies in a community. And I think that that's what we have to do. And hopefully I've been having lots of conversations here in New Bedford and seeing some doors opening up to that conversation. We engaged the chamber a couple of weeks ago to say, what does the business community have to gain by having a healthy community, a productive workforce? A productive workforce means they make more money and more profit, and that's good for all of us. So we need to bring all sectors to a table, I think, to make healthy people and a healthy community. So I'd say communities are gardens to grow healthy people.
Healthy people. Excellent. And to your point about treating sickness, we often have to disable people in order to get them help. Yeah, to make them qualify for certain things, which is also a challenge. Tina, thank you so much for coming down from the Gloucester area. Now, Gloucester and New Bedford share a common population around fishing population. What has been your experience with addressing young people that are attached to the fishing industry that might be experiencing some ACEs in their lives?
Yeah, I know I work, clarify, I'm working up in the, sorry, thank you. I work up in the Newburyport area right now, so I'm also connected to the water. But in the fishing community specifically, I know there was a lot of work going on engaging the families. I think it was like families of fishermen, mothers and wives of fishermen, and really having them be the conduit for the messages that we're trying to get out. Because they were already a trusted organization within the community, it didn't make sense for us to come in as a health department and be pushing messaging. But if we could build the connections with the women who are already, the wives and the mothers of the people out on the boats, the messages from them could be a lot more impactful and taken more to heart.
So a targeted approach, yeah, nice.
Existing connections within the community to get messaging out and helping them create the message that's going to really resonate because they know what, I don't know.
Right, sure. Got to have the right people talking to the right people, right?
Exactly,
Yeah.
with the right message.
Excellent. Questions? We've got one here and then one in the corner. Inside.
Tina, I was just going to ask you about that because I like how Carl mentioned ACEs, and we often do talk about in this community. I hear a lot about the ACE, the adverse childhood experiences. So I really appreciate how you kind of building on the asset. Let's put that aside for a minute. But let's promote, all these assets, which back in the day did work with assets, and it's good to hear that we're still working on that. Do you know, because I know you're from Essex County, if there is anything similar in Bristol County that's kind of working, building up the assets as opposed to identifying at-risk youth and, talking a lot about the ACEs?
Yeah, I do know that this work is catching steam, and so the work, this is the approach that Newburyport's been using for about the last 10 years, but it's starting to bubble up in the prevention the wider prevention community. I know BSAS is promoting some of these, the positive youth development approach and giving people more opportunities for trainings around that. And so I really do think people are realizing that it can be really helpful, and as there's a cry for more supports for younger youth, I think that this is a really easy way to get in the door and start building some of that support and those skills.
Thank you. Tom?
My question is also for Tina. The first, I had 2 questions. The first is very similar to that. I think moving upstream or downstream, as you said, and beyond even prevention is still what we seem to have a brilliant approach. The 2 points were specifically how would a community get that off the ground? I know you're part of a nonprofit, part of a government agency, but another community wanted to get that going. How have you seen that be able to get off the ground and not just sputter by one person? And secondly, so you're data-driven. The problem with things are way early on is looking at your outcomes could be a decade or 2 decades down the road. So how do you support that it's being successful other than trying to just measure your assets?
Great question. So to answer your first question, how do you make this not just a one-person effort? So this really started, I was working with 6 different communities at one time. So I was meeting all the stakeholders and hearing all the great work that they were doing. And really we use the assets as a common language. And so that if I'm talking to a school superintendent and they know what the assets are, or positive youth development, it really has to be something, to your point, that's adapted by the whole community so that it's not just one person. But the other piece of it too is that it's not this totally new thing that you have to retrain everybody on and everybody has to shift. It's just thinking about what you're doing and thinking about your intention. So schools, after school, organizations, YMCAs, they're already doing this. They're already helping to support the kids. And so it's identifying those beacons, if you will, in the community and saying, you guys are all in this together. Here's a set of language that you can be using when you're talking to parents or talking to the youth so that it's a unified approach. And to your second point, sorry, excuse me, the data, yes, thank you. So we do survey our students every 2 years in our data. The survey that we use has the measure of the 40 assets, but it also has some of those, the 4 core measures that DFC requires. So we are able to look at the correlation between an increase in assets for our community and the decrease of risk behaviors. We obviously aren't able to draw any causation from that. But that's what we use, and so Newburyport trend data over the last 10 years, you can see the assets increase as the risk behavior decreases. And so we've been able to use that to secure funding. We have private foundation funding right now, but we'll be able to looking to expand that. We also do consulting for groups who are interested in bringing this to their own communities. So if you're interested, come find me after.
Great. And locally, unfortunately, we're out of time right now, but I'm sure the speakers will be here if you have some specific questions. The Greater New Bedford Youth Alliance, GNBYA.org, is a local coalition of youth-serving organizations that are doing this work, and some really exciting places to connect. So I would encourage you, for those looking for local resources, to connect with that group. And so my only shameless plug here is something for everybody, because the fact is that we've been talking about helping everybody in the community, changing the world. But unfortunately, or fortunately, there's a need for a lot of self-care, because you can't fill somebody else's cup if yours is empty. So there's a group of us putting together Heal the Healer. It's the third annual. It's Friday, May 3rd. We've got CEUs, food, massage. It's an opportunity for all the healers in this room, our first responders, the social workers, to come together on that day to celebrate what we do and to take care of ourselves and fill our cups. So if you're feeling a little burnt out, come check it out. I guarantee you that it'll be a worthwhile experience for you. We've got some great speakers, a variety of different folks, and so I'm over my time now. So I'll stop right now, but you can sign up by going to mentalhealthsouthcoast.org. Thank you. Let's hear it for our speakers.
So we are approaching the end of our program. We're not quite there yet. We're almost there. I still need your assistance for just a few more minutes. We're going to go just a bit out of order. We're going to have our call to action from our State Representative Hendricks. And then after that, we'll go into our breakout sessions, which will be led by Shai Fuxman. And so if you just hold with us just a few more minutes, we really need your input. A big piece of this meeting today was to get your community input for our strategic planning process. So if you could just hang with us until the end, it will be very helpful because your input will be needed. So, State Representative Hendricks is serving in his first term in Massachusetts House of Representatives, representing the 11th Bristol District, including Acushnet in the north end of New Bedford. He was raised in New Bedford and graduated from New Bedford High School, Temple University, and University of Massachusetts School of Law. In addition to serving on Beacon Hill, Representative Hendricks represents injured workers at the Department of Industrial Accidents through his law practice. At the State House, Representative Hendricks has been appointed to 4 key committees, including Judiciary, Housing, Veterans and Federal Affairs, and Redistricting. These committees will soon begin reviewing thousands of proposed bills. He has sponsored 5 bills himself related to improving worker compensation outcomes and has co-sponsored 99 other bills in important legislative categories, ranging from education funding, health care, economic development, support for his first responders, and importantly, fighting the opioid crisis. He has also joined several caucuses at the State House, including Gateway Cities and the American Portuguese Caucus, to strengthen his voice on Beacon Hill, a recovering alcoholic who has been sober since 2009. Representative Hendricks has been an advocate for the recovery community long before he ran for state representative, ensuring that those fighting addiction have a voice on Beacon Hill was a primary motivation for Representative Hendricks to run for state representative. Please welcome State Representative Hendricks.
Thank you. Hello, everybody. Thank you all for being here. It's so great to see so many faces in the crowd. Some that you recognize, some that you don't. I just want to thank the mayor for being here earlier. He has been a leader on this issue, as well as the Chief Cordero. And thank you for everything you've done so far and what you continue to do. It really is amazing that we have a police chief that really can articulate the issues that we're having, articulate this problem, articulate this crisis that we're having. And I want to thank the commissioner, who is, I think, left, but I also want to thank the former commissioner for all the work you have done in the past. I don't know if you mentioned it in your remarks, but she was the first official in Massachusetts to categorize the opioid crisis as an emergency. And I think that just goes to show you how this state has been on the forefront of not only dealing with it, but trying to solve the problem. I was going to start off my remarks with all sorts of data and all, like your TED Talk, but I thought that was silly because one, the commissioner already did it, and two, we all know it's a crisis. You don't have to see another statistic to know that this needs to be solved yesterday. And I just want to thank everybody for acknowledging that. I think everyone in this room either knows someone who has died from addiction. I have people I played baseball with who are dead, people I went to school with who are dead, people I went to college with who are dead, people I went to law school with who are dead, and colleagues who have just died and gone away. And it really is remarkable the level of devastation that this disease has caused. So in having said that, I thought it would be more appropriate just to outline some of the legislation and some of the bills that we have up at the State House to solve some of these problems. This is a bill which I aptly like to refer to as treatment, not prison, which the chief alluded to in his opening remarks. Basically, if you come out of prison or come out of some criminal justice system and you're in treatment and you relapse, you're not thrown back in prison. That is perhaps the most detrimental way to deal with the opioid crisis, by throwing them back in concrete walls. So what this would do is it would revamp someone's treatment plan, noting that they had a relapse and that they need further treatment. We also have a bill that would mandate that all emergency personnel are aptly able to handle an opioid overdose in the line of duty. A lot of emergency personnel already do this, but this mandates that cops and fire men and women also are equipped to handle these types of situations. We have another bill that isn't as flashy, that is basically a study, but this study would evaluate the availability of detoxes in programs like that, clinical stabilization programs, transitional support, residential and home services. Again, it's just a study, but I think data is how we're going to solve this problem. And I want to briefly thank the folks at BioBot for that remarkable presentation. I think that's, when you had your presentation, I leaned over to the chief and said, this could be the key that solves this problem, data. So thank you, and I encourage you to keep that up. And this study would, at the end of the day, be there to reduce costs. When I went to detox the second time, I went to Plymouth. The name of it, High Point in Plymouth in 2009, and my mother had to pay $3,500 for me to go there. If I didn't have a support system, if I didn't have a family, I'd probably be dead today. If it wasn't to be able to swing that $3,500, and I was in a lucky position. I had a place to go after detox. I had a support system. I had people around me who were encouraging me to stay sober. It's easy to get sober, but it's hard to stay sober. And I think that any study that highlights the data on that point to help that is going to be great. We also have a bill that limits the liability of those trying to help people during an overdose. And we have a bill that will provide access to care for children with prenatal exposure to opioids. And also, I'm going to try like hell to get money for this opioid task force. It's my top priority. As a freshman legislator, I can't come here today and say, I'm going to get this money for you, but I'm going to do everything in my power to get money for this program, because reaching out to the community the way New Bedford Task Force has done is perhaps the most encouraging thing I've seen since becoming a state representative. And I want to get every resource available to that program. So thank you all involved with that. One more thing I just want to say briefly. By a show of hands, who parked in the Elm Street garage today? Okay, so did I. So a young man lost his life in that garage due to this very disease on Saturday, less than a week ago. So when you go there today, when you go back to your car, think about that young man. Think about the sense of urgency that we all need to do to solve this, because our efforts here today weren't in time for that young man. And there's going to be a lot more to suffer before this is completely solved or mitigated to the point where it's not as much of a crisis. So think about that in the work that you do. Everyone's doing great work. Everyone's working hard. But if you can work harder, do it. Okay? Also, panhandling. Panhandling is a symptom of this disease. There's a lot of disparagement about those poor souls suffering on the streets and asking for money to support this very addiction we're here to solve. So I doubt anybody in this room speaks disparagingly about panhandlers. But when you open up your Facebook and you see someone taking a picture of someone looking for money on the streets, or someone whose condition is so bad that they've resorted to that type of behavior, don't get mad. Okay, we need to get sad, not mad about panhandling. And there's a lot of anger about these people. It's a symptom of this disease, so please remember that. When you have someone speak disparagingly about panhandlers, highlight the fact that this is a disease and that is a symptom of it. And I know everyone in this room is doing good work, so keep up the good work. You know that you have an ally at the State House relative to this crisis, and I wish everyone well. Thank you.
Thank you, Representative Hendricks, for those encouraging words. So this is it. This is the last segment of our of the day, and we're gonna hear from you guys now. So I'm just gonna quickly just give you the instructions. We have, as you see, 4 different spots in the room where we're gonna have conversations. So the conversations are gonna be grouped by prevention, intervention, treatment, and recovery. You can choose whichever of those 4 feels most comfortable for you, which group you feel like is your work relates to most. Our work might feel like it crosses across different areas, but just any group really, and the idea really is to hear from you, so there's no wrong group to go to. So we're gonna have the prevention people here, intervention over there, treatment over there by the buffet, and the recovery in the back. There's going to be 3 questions. We're going to have a facilitator and note taker. They'll remind you what those questions are. They're the same ones I pointed before. Thank you for staying till the end, and please do share your thoughts with us, and really appreciate it. Thank you.